يا الله. ما عم بقدر فوت على السكرين.
يا صلاح شوف الدكتور يعني من اني يفوت من يا
ما عم
شباب
بقدر فوت على السكرين. طلعت لي
نفس اللي بتطلع.
يلا رح نشوف دقيقة.
يلا
عم جرب فوت ما عم بقدر. خليني نفوت شوف.
دكتور جون الصورة واضحة عندنا.
حاضرة.
واضحة. ماسكولوسكيليتال ايميجينج.
عظيم. فيري جود. هذه اللي بدي اياه. اوكي. سامعين الكل؟
دكتور واضح جاهز ان شاء الله.
اوكي.
ايه اوكي دكتور عبدالنور سامعينك.
يلا. Radiologic imaging plays an integral role in any orthopedic surgeon's practice. إذا بتعرفوا يا شباب كل شيء بنعمله بنعتمد على الصور. It includes the diagnosis and treatment of trauma, neoplasm, arthritis, inflammation, infection, and degenerative conditions. If we want to do a total hip, we judge which type of instrumentation we're going to use. We use it for measurements, for leg lengths, for whatever means we need to benefit the patient. There's a spectacular array of imaging technologies, and these are available. But what I'm going to give you today is the essential imaging techniques that we use in orthopedics. We'll start with radiography. What about the principles of radiography? They are obtained by projecting X-ray beams through an object onto an image detector. The beams enter the object and are detected by an image detector. The image produced is a projectional map of the amount of radiation absorbed by the object along the course of the X-ray beam. The amount of whiteness of the image is a function of radiodensity and thickness of the object. If you have a plate, it will appear white because it is what? Thick. The amount of radiodensity is thick, so it will appear as white. The denser the object, the more radiation is being absorbed, and hence we get a lighter or whiter image. Metal objects and bone are very radiodense. إذا بتطلعوا بالcortex بتلاقوا it's more dense, it's more white than the medullary cavity. So the amount of radiation absorbed is much more in denser objects, and for this reason it appears white. With radiology, we have created digital radiography. A lot of the treatments, a lot of the X-rays, a lot of projections occur on X-rays to individuals. And digital radiography was created, and it is used often Image processing and distribution are achieved through a picture, archiving, and communication system. If you look at this right-hand slide below, you see a finger pointing to an X-ray on a viewing box. We have these X-rays which are transferable. It's important for education. It's important for treatment and advice. It's recorded on computers. This lecture has many X-rays. It's recorded on computers and we can transmit it to everybody. Digital radiography versus conventional film screen radiography. Film screen radiography has a higher spatial resolution, meaning that we can identify certain objects more clearly. There is an improved contrast resolution for digital radiography. It means the technique is comparable in terms of diagnostic efficiency. So this is very important. The radiation dose, the effective dose, is in millisieverts. And from now on, I'll speak about MSV. Other radiation doses used are the RADS, the REM, the Roentgen, and the sievert. Radiation exposure. If you look at the United States, you have a continuous radiation exposure from natural sources. The average person in the United States receives an effective dose of 3 MSV per year from naturally occurring radioactive materials and cosmic radiation. If you compare this to a chest X-ray, it's only 0.1 MSV. So you can imagine how much radiation is being received naturally. What are the advantages? They are most commonly used medical imaging throughout the world. First of all, it's cheap. It is inexpensive. And real-time radiographic imaging or fluoroscopy allows instantaneous feedback on stress radiographs, angiography, and orthopedic interventions. If you're doing a close reduction, you need fluoroscopy to confirm your fracture is reduced. So you see, we use it in every day's work program. So keep this in mind. What are the disadvantages? Radiation is transmitted to the patient. It is not effective for soft tissue imaging because of poor contrast resolution. If you have a lesion in the soft tissues, in the muscles, it's not well identified by radiography. If you have an infection, the only thing is you can see cellulitis, and this is what we used to see in the past. Nowadays, you young people have an advantage over us. You can see much more. The problem with radiography is that the images obtained are always magnified. But what we can do is we can apply measurement standards. These can be placed with the object to allow determination of the proper magnification. And although most medical X-ray beams do not pose a risk to a fetus, there is a small likelihood that serious illness and developmental problems can occur. The actual risk depends on the type of imaging and the study when it was done. Was it done during the beginning of the first trimester? Was it done during the last trimester of pregnancy? Plain radiography and percent accuracy in diagnosis has helped us in identifying lesions, infections, or tumors. Let me tell you, fellows, I refuse to review an X-ray, a radio imaging, asking me, is this a tumor, without seeing a plain X-ray. We can identify what the lesion is in 70% of the cases. You have to keep this in mind, young people. If we know the location within the bone, we can say, most probably, if it's in the epiphysis, is it what? A giant cell tumor? Is it a chondroblastoma? Is it an eosinophilic granuloma? If it's in the shaft and the diaphysis, is it a Ewing's? If it's in the metaphysis, is it an osteosarcoma? These locations on plain X-rays help us significantly in identifying the lesion. So, how do we assess bone lesions on radiographs? The age is important. That's the first question we ask. How old is the patient? Why? Because there are certain lesions which occur in tumors, occur at a certain age. Multiple myeloma occurs in older generations. Ewing sarcoma, younger. Osteosarcoma, likewise. So you have to know about the age. The location within the bone. Is it in the epiphysis? Is it in the metaphysis? Is it in the diaphysis? The margin zone of transition. The margin zone. This is very important. If there's sclerosis around the tumor, we say it's a benign tumor. If there is ill-defined margins, and it is infiltrative, we say it's an aggressive lesion. We look at the periosteal reaction. If there's an onion peel appearance, we can say probably it's a Ewing's or an eosinophilic granuloma. If the cortex is eroded on plain radiography, we say it's aggressive. What about the matrix? Is the calcification that occurs with cartilage? Is it the cloudy appearance that occurs with bone? So these you need to identify on plain X-rays. Of course, the size and number of the lesions tell us how aggressive the lesion is. I spoke about cortical involvement. If there's scalloping, if there's erosion, all these we see on plain X-rays, but the soft tissue component remains weak. Let's look at certain lesions. If you see a lesion occurring in this region, which is in the metaphyseal epiphyseal region or epiphyseal metaphysis, you see that there is sclerosis. It's a well-defined lesion. It looks benign. So on plain X-ray, we can say it's a benign lesion. This is a less defined lesion. We see that the boundaries are clear. We see normal tissue in one region and we see abnormal. So we clearly can identify the boundaries of the lesion. So this is more aggressive than a sclerotic lesion, but not very aggressive. It's an active lesion. So always we ask the question on plain X-rays, what is the lesion doing to bone and what is the bone doing to the lesion? Keep this in mind, you young fellows who are sitting for the board exam. Stand on your 2 feet, and if they show you a lesion like this, the very first thing you say, what is the lesion doing to bone and what is bone doing to the lesion? This is an infiltrative lesion. It's a moss-eaten lesion. It tells you that the tumor is aggressive. This we see on plain X-rays. We see it. So you have to take a plain X-ray. اكره شيء علي اللي ما بيجي لعندي مريض عاملين له كل شيء الا البلين اكس-راي يا شباب. This is forbidden. This is an infiltrative. This is a permeative lesion. It's a very aggressive lesion. Let me tell you, like, this is moth-eaten. What mode we say? This is a very aggressive lesion. It's involving the whole bone. We see it on plain x-rays. So you have to keep this in mind, okay? And this is permeative. You see, it's involving the whole bone. This is an osteosarcoma. It's destroying the whole bone. You can not see any boundaries. So a plain x-ray is very important in the differential diagnosis. This is a schematic drawing showing the sclerotic lesion, the less sclerotic, the ill-defined lesions, the moth-eaten, and the permeative. يا شباب ما تنسوها، عم فسركم اياها لحتى لان اذا سالناكم هيك تعرفوا شو عم نحكي. Look at the periosteum. Look at the periosteum. Is it onion peel? Is it a hair on end appearance? Do we have a Codman's triangle? What are these? If you have a hypertrophic osteoarthropathy, ما تسألوا كم مرة جبعتوا لي كيس وقالوا لي this is a tumor. Could this be a Ewing sarcoma? Yes, شباب, this is an elderly patient. This patient with the lower x-ray on the left-hand side has a periosteal reaction, and the diagnosis is hypertrophic osteoarthropathy. You see nothing in the medullary cavity. This second x-ray from the left is a periosteal reaction. There is even a hair-on end appearance in both x-rays in the center. What do we mean by hair-on end? When a tumor infiltrates and pushes the periosteum away from the cortex, what happens? The vessels become perpendicular to the cortex, and there is bone formation around the vessels, bone formation around the vessels. And this is the hair on end appearance. Some call it the sunburst appearance. And when these tumors penetrate the cortex on the extreme right, it penetrated the cortex and pushed the periosteum away. And it formed a triangle. This is called the Codman's triangle. Please keep these. All these are read by plain X-ray. This is an example of a Codman's triangle. The tumor has infiltrated the cortex and it's elevating the periosteum. It formed a Codman's triangle. This is a sign of malignancy more than a sign of benignity. So be careful of this. On the other hand, if in the matrix you see a solid appearance, a cloud-like appearance, an ivory-like appearance, these are bone-forming tumors. These occur in osteosarcomas. On the other hand, if you see a lytic lesion, which is cloud-like, which occurs, we call it the ground glass appearance, or it's like مثل الإزاز, and this is a giant cell tumor. But why do we identify it as a giant cell tumor? The patient is in the 40s. The patient has the lesion in the epiphysis, and you see that there's a lytic lesion. And it's very important to know that giant cell tumors, most importantly, occur on the lateral aspect of the distal femur, not in the center, okay? On the other hand, if you see an ivory-like lesion, and it's so dense as the X-ray on the lower right-hand side, this is prostate cancer. So if you have all these in your mind, then you can make a diagnosis before even going into CT scans, MRIs, scintigraphy. You can have an idea. This helps you. On the other hand, look at cartilaginous lesions. You have the benign cartilaginous lesions such as enchondroma, and you have the more aggressive, the chondrosarcoma. You look at the calcification, if it's smooth, if it's rough, if it's stippled, if it's flocculent, if it's rings and arcs. From these, you can be able, plus other signs of pain, and erosion of the cortex will tell you whether the cartilage tumor is aggressive or not. Okay? Look at the X-ray below on the right-hand side. The right-hand side, you see popcorn appearance. And the calcification is more dense than the calcification seen in the medullary cavity. So it tells you that this is cartilage. On the left-hand side, you see you have a more aggressive lesion. It has penetrated the cortex. And this is a cartilaginous lesion, but aggressive, a chondrosarcoma. So, if you have cortical involvement, it's very important by plain X-rays. You see that the cortex is elevated. You see that it's balloon-like. It's an expansile lesion. This is very important to realize. On the other hand, you can have, as in the low end of this slide, a more aggressive lesion where it destroys the cortex. When you come to classification of tumors, I'm not going to go more because there are lectures to come on tumors, and you have the latent, you have the active, you have the aggressive lesions. You have to know these by plain X-ray. Don't forget that other lesions can occur besides tumors. In the left-hand side, the X-ray of the elbow, this is a patient with rheumatoid arthritis. The synovial tissue has eaten up the cartilage, but it looks benign. This is a rheumatoid arthritis. On the other hand, in the X-ray in the center, we know that with rheumatoid arthritis, there's a protrusio acetabuli, and you see that there's rarely osteophytes. Let me tell you, there are patients that have had total hips. The resident comes to me and tells me, we did the total hip because the patient has degenerative arthritis. I look at the plain X-rays before the total hip. I don't see any osteophytes. I tell them, what? They said, well, he has degenerative. Look at the way it is. Well, in rheumatoids, we can have secondary degenerative arthritis, but the main issue is that you have an atrophic arthritis. The cartilage atrophies. You have narrowing of the joint, weakening of bone. As a result, the hips go inside, and you have an autopelvis, a protrusio acetabuli. What else does plain X-ray tell us? Of course, many of our orthopedic surgeons live on these cases. This is a fracture through the waist of the scaphoid bone. And it tells us whether a fracture exists or not. But you have to follow the technique. We know that when you have a scaphoid fracture or the patient presents with pain, you have to take multiple views to be able to tell you where the fracture is at times, not always. Now we come to computed tomography. It demonstrates the details of bony anatomy better than any other study. When we get fractures of the spine and we want to demonstrate what are the bony structures that are displaced, not the neurologic structures, not the nerves, a computed tomography helps us, besides the plain X-ray, but far more with the computed tomography. And computed tomography uses Hounsfield units to identify the tissue types. We have multi-detector row arrays. It has an improved resolution in the longitudinal axis. Yes, when we had CT scans, we were so happy because we were able to identify soft tissue swellings. We had a fairly good resolution. We were happy. And it had a decreased data acquisition times. There was an improved spatial resolution, improved quality of reconstructing algorithms, and you have a reduced artifact caused by hardware. But I'll tell you, we still have artifact interference. I will be showing you this. It does help us. It helped us a lot in the past about the nucleus pulposus, better than myelography. Imagine we had to inject to see our discs in the past. With the CT scan, we really had to inject unless we were forced to do a combined CT with the myelogram. CT may be helpful in differentiating disc herniation from scar, but you will see that later on, and MRI helps us more. We inject an intravenous contrast material, and this is taken up by the scar. I'll tell you, young fellows, if in the board we tell you, how can you distinguish between a disc and the scar? The scar has circulation. When you inject a contrast material, it will go through the scar. The disc is avascular. Many times following surgery on discs, we have recurrence of the pain. We want to know, is the recurrence from scar tissue or is it from a disc popping out in the leftover disc material within the space? So this will help us, but MRIs would help us more. This is an example. On the left hand, we have an axial cut with evidence of a disc. You see it in the D region, and this is pressing on the cord or whatever, nerve root, etc. Following the injection of contrast material, you see that there is an uptake, and this tells you what this patient has is that he is a scar former, and you have to keep this in mind. This is very important to distinguish between a disc and scar tissue. Frequently used with contrast material, we can do arthrographic CT and myelographic CT. These help in the diagnosis. CT digital radiography also exists. It gives us an accurate demonstration of the leg length discrepancy. One of the most difficult findings was in the past when we used orthoröntgenograms to measure the leg length discrepancy. We had problems when the patient had the flexion contraction. We could not have really a very accurate difference in the leg length. With CT, I'm doing a sagittal or a lateral scanogram will help us and give us an accurate measurement. So keep this in mind. One of the questions we can ask in the board is, we can show you a patient who has a leg length discrepancy with the flexion contraction. What is the best way could you tell the leg length discrepancy? Tell them by CT, by doing a lateral scanogram. Even in arthrographic CT scans, we can make use of it. It can tell us about slap lesions. What we mean by slap lesions is when you look at the labrum that surrounds the glenoid fossa, you see it's triangular in shape. If you have an avulsion of the superior portion of the labrum, we call it a slap lesion, and you can see that the dye or the contrast would go through the defect and you can identify it. CT with contrast best demonstrates joint incongruity after closed reduction of a hip dislocation. Let me tell you something. This is very important. Many times you get, if it's an adult and he has a traumatic hip dislocation, many times we can have loose fragments. or we can have marginal impaction. Who do you think, what radio imaging helps us most? It's the CT scan. Keep this in mind. It's useful for measuring the cross-sectional dural area in the workup of cervical spinal stenosis. When you have patients coming to you with cervical myelopathy, when you have patients coming to you with a canal width of less than 10 millimeters, when you have patients coming to you when they're walking, they tend to fall, you want to confirm your diagnosis, a CT scan will help you most. You can tell the exact measurement of the cervical spine. In addition, what does CT help us? It helps us in degenerative arthrosis, subtalar arthrosis. It will tell us in subtalar fractures, in fractures of the calcaneum, fractures of the talus. It gives us an accurate measurement. And if we have a fracture of the tibial plafond, young fellows, one of the very first things is we should ask for a CT scan to describe the fracture further, to help us in our operative planning. This is a fracture through the neck of the talus. It would tell us about this fracture. It would tell us, you know, Hawkins classification. Hawkins, if the displacement is significant, if there is a talonavicular dislocation, it would give us an idea about the avascular necrosis or the risk of avascular necrosis, especially when you have a dislocation of the calcaneus underneath the talus. We know that Hawkins himself described avoidance of avascular necrosis on plain X-rays. You have to know both on plain X-rays. If on plain X-ray, after some time, you see that there's significant osteoporosis of the dome of the talus, this would tell you that this is a viable dome. Okay, keep this in mind. X-ray can be used in certain ways. CT scan can be used in certain ways. This is a lateral or a sagittal CT scan of the spine, of the cervical spine. We can measure it both in the sagittal direction and through the axial route and the width of the canal. If it's less than 10 millimeters, we will confirm that is spinal stenosis. But mind you, let me tell you something. I was reading several articles recently. There are many people who have narrow spinal canals and they never complain of symptoms. So keep this in mind. I'll be telling you about this later on. CT has a high 97 to 100% sensitivity for cervical spine fractures. Look at this fracture. It's a fracture dislocation of 3, 4, 5, 6 over 7. Now I come to a point, 6 over 7. It's very important. Whenever you get a cervical spine injury with signs and symptoms of paraparesis or quadriparesis, you should ask for a CT scan. You should ask for a CT scan at the level, mainly at the level of C71. Why? Because the shoulders come in the way of a plain X-ray. If you don't have a CT scan, then you have to take a swimmer's view, meaning traction proximally on one arm and traction distally on the other arm to get the shoulders out of the way to see C71. For congenital spinal anomalies, CT images shows additional abnormalities. We can see whether we have anything, failure of segmentation, failure of formation, combined deformities. A CT helps us in many ways. CT evaluation of sacral and acetabular fractures. Gentlemen, I live on them. A CT tells us more about the anterior column, posterior column fractures, transverse fractures, loose fragments within the joint. I love CT scan, but I don't love the radiation caused by it. CT is superior to radiography for assessing tibial plateau fractures. I'm preparing a lecture to give in Egypt on the 3-column fractures. CT is the basis of my lecture. You have to know this. And in the ankle and foot, CT is often used in the preoperative assessment of tibial triplane and calcaneal fractures. It's important for evaluating subtalar joint injuries and diagnosing tarsal coalitions. We used to take plain X-rays, of course, for tarsal coalitions. But we have to take the Harris views, we have to take oblique views, we have to take lateral views. With the CT scan, it describes exactly what kind of synostosis we have. So you have to keep this in mind. Dynamic CT scanning is the test of choice for the atlantoaxial rotary subluxation. كلكم تعرفوا شو معنات Gris's syndrome. Gris's syndrome is when you get an infection in the pharynx. It was very common during the tuberculosis years. This infection causes inflammation. It weakens the atlantoaxial joint. CT will tell us whether there's subluxation, dislocation in the anterior or posterior direction. So CT is very important in these cases. Like in this case, this patient had a pharyngeal abscess with inflammation, weakness of the ligament, and as a result, there was a subluxation in the anterior direction. You have to pay attention to this. So the principles of CT, it uses X-ray beams to produce tomographic images or slices of an object. Multiple images are obtained and reassembled to generate a 3-dimensional image. X-ray densities are measured in Hounsfield units or CT numbers. What are the advantages? It gives us tomographic images. It helps us by using these cuts to identify certain locations. For instance, if you have an osteoma and you want to identify it, the cuts, if they're less than 1 millimeter or 1 millimeter at most, could identify the site of the needles. So you have to pay attention to this. It has a high contrast resolution. The latest generation of CT scanners uses multiple detector row rays, which leads to improved resolution and short acquisition times. Images like radiography are processed digitally. Images in a plane other than the one in which the original images were obtained can be reconstructed to give you a different perspective of the object and tissue of interest. Gentlemen, nowadays in trauma centers, they have the spiral CT in the emergency room. In the past, we used to waste so much time sending the patient for plain X-ray. With the spiral CT, it helps us tremendously in the spine. It helps us in multiple planes to make a diagnosis. Magnification artifacts that occur in plain radiograph do not occur with CT. So we don't need an adjunct measurement if we're measuring a leg length discrepancy. Direct measurements can be performed on the scans. CT can be combined with arthrography or myelography to evaluate specific joint or spinal abnormalities. CT is useful for injections. The intervention radiologist lives on CT He takes his biopsies. He uses his core biopsies. He directs the needle to the area where he needs most, and he aspirates and sends to pathology. You can also aspirate fluid areas. These are identified by CT scans. And CT provides better detail. Don't forget this. This is a question I like to ask. If you have a choice between CT and MRI, which would give you a better detail of the cortex and trabecular bone? Of course, you should answer CT. What are the disadvantages of CT? I'll tell you. I was disappointed. Last week, I got a 1-year-old child with a mass involving the cervix, the neck, and shoulder area. What was requested? A CT scan. Ya Jamea gives the child a huge amount of radiation. We have had cases of leukemia and various tumors from our faults, so be careful about this. Most CT slices require about 1 second, which is longer than the time required for a radiographic image. The scans are subject to motion artifacts. Yani if the patient is moving or anything causing motion, they can be caught by CT. CT is subject to artifacts due to metal objects. Metal has high X-ray density, which prevents sufficient X-ray beams from being transmitted through the body part. These result in an artifact called beam hardening. This is a question I love to ask. What are the artifacts recognized as beam hardening? And it appears as streaks of white or black that can be obscured, that can obscure the anatomy adjacent to the metal object. These are the beam hardening. You see, if there's a body and it can create an artifact, any metal. So you have to pay attention to this. CT can be impractical for obese patients. You know that. I wasn't aware of this, but recently I became, when I realized that most scanners have a weight limit. Not that the obese patient cannot pass through the tube, but they have a weight limit. Above the limit, the table that carries the patient through the scanner, if he's very obese, won't move, or it may even break. So you have to understand, obese people are difficult to have a CT scan. Why? Because probably they cannot pass through the tube, but the scanner table won't move. It can break. CT produces higher radiation exposure than plain radiography. As a matter of fact, CT provides the highest radiation. That's why I was very upset with the mass of this 1-year-old child. We know that these younger children, when they're exposed to radiation, they have a higher incidence of leukemia. It is generally contraindicated for pregnant patients, except in life-threatening circumstances. If you have a woman who's pregnant, involved in a car accident, and has a severe trauma, you have no choice. You have to do a CT, then you're allowed to do it. MRI and magnetic resonance arthrography. We all know that MRI is excellent for evaluating soft tissues and bone marrow. It is ineffective. This is what I've stressed repeatedly. It is ineffective in evaluating trabecular bone and cortical bone. So this is very important. These tissues have virtually no hydrogen nuclei. ما عم نحكي لأنه سميك أو لا. They have no hydrogen nuclei. And the way we record MRI is with the use of hydrogen nuclei. It's used to evaluate osteonecrosis, neoplasms, and infection. And don't forget about trauma. It allows for both axial and sagittal representations, but has its contraindications: pacemakers, cerebral aneurysm clips, shrapnel, or hardware in certain locations. What are the basic principles? Radio frequency pulses on tissues in a magnetic field is sent. These radio frequency pulses are projected on tissues. And these record images in a desired plane. You should know that MRI does not have ionizing radiation. It works through protons and neutrons. Okay? And the field strengths can vary from 0.5 to 15 Tesla. We have certain measurements that we take. The signal intensity, the T1, the T2, the TR, or the repetition time, or the echo images, or the fat suppression techniques. All these are techniques the intervention radiologist uses to decide what the lesion is. You have to know what and when you have dark images, bright images, and gray images. We all know that T1 cortical bone is dark. Osteomyelitis is dark. We know that there's a lot of edema and swelling and fluid. It is dark in T1. Ligaments are dark. Fibrocartilage is dark. Hyaline cartilage is gray. And it's gray in T2 weighted images. The meniscus is dark. You have to know these because this is the way you can identify the substance or the tissue or whatever you're looking for on the screen. Okay? You have to know that T2 is bright wherever you see fluid. You have to know that muscle is gray in both T1 and T2 radio frequency images. You have to know these. You have to know that an intervertebral disc, which is dry, is black, dark. When it has fluid, it's less dark. You have to know these. On T2, I'm speaking. Nuclear magnetic moment of these particles deflected by radio frequency pulses results in an image. The use of surface coils decreases the signal to noise ratio. Body coils are used for large joints and even for smaller joints. These are coils which contain magnets in them, and these distribute the hydrogen or the protons or the neutrons. Sequences are developed to demonstrate differences in T1 and T2 relaxation between tissues. Yani, you have an activation of the hydrogen, the protons, the neutrons, and then during relaxation, depends on T1 or T2 to give you the presentation. T1 images weighted toward fat. Typical, they have a time to repetition which are lower than 1,000 milliseconds. T2 images are weighted toward water. So T1 is weighted towards fat. T2 is weighted toward water. A question I like to ask, is T2 weighted towards water or towards fat or towards etc., muscle, etc.? You should answer towards water. It gives you a bright. T1 will give you a bright image on fat. That's one of the differences between T1 and T2. Another thing, the difference between T1 and T2. T1 has a shorter repetition time and a shorter echo time than T2. T2 has a long repetition time and a higher echo time. So a longer, higher echo time. Dark on T1 and bright on T2 weighted images. I'm telling you, these are the شو يا خالد؟ خالد
دكتور جون هذا واحد دخل
طيب ليك
الآن بنص.
am I clear until now?
Yeah, everything is good. Continue.
I want to ask the attendees, are they happy?
Yes.
Okay,
All-
great.
Listening you.
Okay. قريبا نعطيكم 5-minute break.
يعني الآن
لا مش هلا، لا بدي اخلص the principles وبعدين.
Okay.
So إذا بتطلعوا, what are the substances that are dark on T1 and bright on T2 weighted images? Water is dark on T1. Cerebrospinal fluid. هلا بدي اسالهم في questions من سوء الحظ حاطينهم بالفحص في البورد. بنفرجيكم an MRI of the spine. نسألكم, is this a T1 or T2 weighted image? صدقني, many times people guess wrong and they don't know. You have to know that with T2, water, cerebrospinal fluid, acute hemorrhage, and soft tissue tumors are bright. These are dark on T1. You have to memorize this. Tissues showing similar density on both T1 and T2 weighted images is mainly muscle, cartilage, fibrocartilage. These are similar. Cortical bone, rapid flowing blood, fibrous tissue. Muscle, I told you, is gray. Hyaline cartilage, gray on both. What is bright in T2 is fat. What is bright in T1, I'm speaking, fat. In T2, it's water. Don't forget this, okay? T1 weighted images are best for demonstrating anatomic structures. We call it the anatomic description. You have a high signal to noise ratio. T2 weighted images are best for contrasting normal and abnormal tissues. But يا شباب, لازم تاخدوا these, they are present in many books, and sit and memorize them. This will help you in reading your MRI. It will help you tell your professor or tell your students whether it's a T1 or T2. You have to know whether there's fat suppression to make it more bright for T2. These are all important. Now let's come to osteonecrosis. It has MRI, the highest sensitivity and specificity for early detection. It detects early marrow necrosis. It detects ingrowth of vascular mesenchymal tissue. Specificity of 98% and high reliability for estimating the duration of the osteonecrosis and the extent of the disease. Diseased marrow are dark on T1 weighted images, and it allows for direct assessment of the overlying cartilage. So you can see how important an MRI is in diagnosing osteonecrosis. Mind you, let me tell you something. CT scans can quantitate the amount of necrosis of the head of the femur or any head, like in the humerus. But what gives us details is osteonecrosis. In osteonecrosis is MRI. Infection and trauma. It has an excellent sensitivity to increased free water. It shows areas of infection and fresh hemorrhage. It's dark on T1 weighted images. If you recall, I told you with infection, there's inflammation. And this would give you a dark image on T1, while bright on T2. It's excellent for occult fractures. It helps us, especially in patients who have hip fractures. لما بجيبوا لك على emergency room a patient with a hip injury, you take an X-ray of the hip, you hardly can see a fracture. If you do an MRI, it will help you. It's excellent for this. Don't forget that you should remember that MRI findings is excellent for bone marrow edema. MRI is very useful for the early diagnosis of musculoskeletal infection. In acute osteomyelitis, MRI typically shows low to intermediate T1 and high T2 signal intensities. Areas involving the medullary canal, the cortex, and soft tissues corresponding to bone marrow edema. Never forget this. We might give you an MRI, like in this slide, the X-ray, and tell you this patient has fever, etc. The patient has periosteal reaction. You can see that the periosteum is slightly elevated. You can see that there's inflammation around the whole ankle, and this tells you there's inflammation and within bone. So this will help you and tell you when there is an infectious process taking place or not. What about neoplasms? MRI has many applications in the study of primary and metastatic bone tumors. Primary tumors are well demonstrated, particularly tumors in soft tissue, extraosseous, and marrow. And we know that MRI is excellent for skip areas in the bone and for satellite lesions in the soft tissues. They help us. Coming to nuclear medicine. Nuclear medicine studies remain the procedure of choice for seeking metastatic foci in bone. MRI demonstrates benign bone tumors. But nuclear medicine has its place. They are bright on T1 weighted images and dark on T2 weighted images. What are these? The benign bone tumors. So you have to think of this. You have to know it. MRI is also capable of demonstrating many malignant bony lesions. It's bright on T2 images. Differential diagnosis is best made. I'll have to close something. Sorry, one of the electronic instruments went out in my room, thinking that I'm speaking to her. instead of speaking to you. So it's for malignant lesions. We see that it's bright on T2. And you should keep in mind that if you want to give a differential diagnosis of a tumor or a lesion in bone, please don't forget that the plain radiographs are the best. We know that in staff meetings, plain radiographs help us teach the residents in giving them a proper differential diagnosis. In the spine, disc disease is well demonstrated on T2 weighted images. Degenerated discs lose water, therefore they will become darker. Such discs appear dark on T2 weighted studies. The extent of herniation of discs is also well shown. Recurrent disc herniation is best, I told you, is best diagnosed with gadolinium MRI scan. I'm sorry I'm taking a bit long in this section, because this section is the 1/3 and the longest. How do we differentiate from scar? On T1 weighted image, the scar has a decreased signal. If you have a free fragment, you have an increased signal. If you have an extruded disc, you have a decreased signal. On T2 weighted image, scar has an increased signal. Free fragment, increased signal, and extruded disc, decreased signal. Gadolinium can be added in MRI studies. It enhances edematous structures in T1 weighted images. It's also used to differentiate scar from disc. As I mentioned, in the scar, you have an increased uptake, and therefore it projects as such when compared to a disc, which does not change. MRI is most sensitive for diagnosing early discitis, and decreased signal on T1 weighted images, increased signal on T2 weighted images. MRI can help. This is very important for everyone. For everyone. MRI can help evaluate the spine in asymptomatic persons. Yes, Jamia. Many of the population have findings in the spine on CT, on MRI, on plain X-rays, and never complain of pain, never have symptoms. It doesn't mean you have to operate these patients. MRI can help evaluate the spine in asymptomatic persons. Let us take these. Of subjects older than 40, 28% shows cervical spine abnormality. Of subjects younger than 40 years, 20 to 30% show evidence of lumbar disc herniation and never complained of pain. Of subjects older than 60 years, 93% show evidence of degeneration or bulging of lumbar disc and never complained. Biochemical studies show degenerative disc changes as early as the second decade of life. Ya Jamia, please be careful. You have to always adjust two situations. If you have an MRI with findings, always compare it with the clinical findings, and then put the two together and arrive at the diagnosis and decision on the treatment. Bone marrow changes is best demonstrated by MRI. Knee MRI, we all know that it's excellent for identifying ACL and meniscus tears, cysts within the knee, especially when combined with arthrography. It's, how do we do it? We always inject some saline and then inject our whatever contrast media, and we can do an MRI, or we can do it alone. But if you want to improve your joint definition, you have to combine it. Knee derangements are well demonstrated on MRI. ACL rupture correctly diagnosed in 95% of cases. Meniscal changes are also demonstrated. And I'm going to just mention over here, I'm coming to the first, okay. 5 minutes break.
اوكي دكتور جون.
يمكن هلاك تكون ايه؟
لا احنا يعني انت ترتاح شوي 5 دقائق ونرجع عادي.
انا بدي صوتي يرتاح.
ايوه اكيد ترتاح وصوتك يرتاح ان شاء الله. اوكي دكتور جون.
ايوه
خلاص ارتاح 5 دقائق ونرجع. اوكي
انا بيهمني الرأي العام. If they have comments, allow them to ask anything now.
الآن بعد ما تريح.
ايه
اوكي ارتاح، واحنا بنسألهم اذا في سؤال من الشباب لما ترتاح بعد 5 دقائق. اوكي ثانك يو فيري ماتش. ثانك يو.
Okay. Are you ready?
Dr. Jun, we are ready, yes?
You are
With
ready.
you? Yeah.
Okay. Now, sticking to magnetic resonance imaging, we all know that an MRI tells us a lot about the meniscus disease. And we have a classification for tears of the meniscus. And you have to know how to read an MRI. You have to know when the meniscus, even though it has areas of hyperintense signal, it does not mean that it's torn. It can be degenerated, but not torn. We know that on removing the meniscus, we do harm at times, especially in women, where they end up having osteonecrosis of the medial femoral condyle because they have no longer any protection. So you have to know which meniscus is torn, which is not. If you look at the slide below, on the left-hand side, you have a horizontal tear, and it is communicating with the articulation. This is a torn meniscus. The second slide on the left, you see that there is a gap between the meniscus. And this tells you that there is a fragment which is loose and present somewhere in the joint. In the third X-ray, or the third MRI section, you see that there is again a horizontal tear, and likewise on the fourth side. While the extreme right, you see a vertical tear. You have to be able to identify them, and we classify them into 4 types. 1, a globular area of hyperintense signal with no tear. In 2, we have a linear hyperintense signal, but it does not communicate with the joint. Number 3 is a linear hyperintense signal that communicates with the meniscus surface. And then you have the vertical longitudinal tear. This is what you should know. So, in addition, I would like to mention, to complete the knee, is that MRI is best for identification of PCL ruptures. What about shoulder MRI? Shoulder MRI, rotated cuff tears are very well demonstrated. It has a sensitivity and specificity of 90%. Grade 0 tears are normal signal intensity. Grades 1, 2, and 3 tears is increased signal intensity. And we grade the amount. If you look at the slide on the right-hand side, the section of the shoulder, you see that the rotator cuff is detached from its insertion and displacing medially. And you have a significant amount of increased signal intensity overhead secondary to edema, secondary fluid on T2. The morphologic features of rotator cuff tear is grades 0 to 1 tears are normal, grade 2 tears are abnormal, they're recessed, grade 3 tears, definitely there are discontinuity. Capsular labral tears also are identified, and the efficacy of MRI equals that of CT arthrography in the presence of effusion. So you have to keep this in mind. If they ask you, you have an MRI and you have a CT arthrogram, what's your opinion? Which one would you use? You tell them that they have an equal efficacy in identifying tears. What are the general principles of MRI? MRI is similar to CT scanning in that images are produced by reconstruction of the data set. This is very true. MRI does not use radiation or have tissue damaging properties of radiation-based imaging modalities. It uses a strong magnet that generates a magnetic field and multiple coils that send and or received radio frequency signals. All clinical MRI scans image the protons in hydrogen atoms. In a strong magnetic field, the protons line up like countless compasses. A brief radio frequency pulse is applied to the tissue that deflects the protons. When the pulse is terminated, the protons realign or relax along the strong magnetic field. The protons relax at different rates depending on their atomic environment. The weak signal that the proton emits during relaxation allows the detector to detect the properties within the tissue. This is for a radiologist to know. You don't have to know these things, but you should have a general idea about the principle. Contrast on MRIs can be manipulated by changing the pulse sequence parameters and by using TR and TE and T2 weighted images, T1. You have to know these briefly, what each one stands for. Okay, let us take these cuts. Okay, in A, which is the one on the left, the appearance of different anatomic structures of T1 and T2 weighted coronal MRIs of the knee. In A, which is the one on the left, is a T1 weighted image. Fat and bone marrow are bright, and menisci and tendon are dark. In T2 weighted, you see that the joint fluid, the blood vessels are bright. This is the way we can distinguish between the two. I want you, when you record this lecture, I want you to take this slide and memorize each one, the appearance, whether dark or bright or gray, because we asked this in the exam. Signals from fat also play an important role in providing contrast. Fat suppression techniques adds a useful dimension to manipulation of image contrast. We use it to increase our contrast, to increase our resolution. Fat suppressed images are helpful in delineating various structural abnormalities. Now, the strength of the magnet is expressed in Tesla, T units. The stronger the magnet, the higher the intrinsic signal to noise ratio, which can improve imaging speed and resolution. You have to know that there are several types of MRI scanners. You have the conventional one, which is large. It has a small bore and it has a weight limit for the patients. Otherwise, they'll break the table. It won't move. It takes longer than CT scanning. Patients with claustrophobia cannot use it. Then you have the open MRIs, which is good for the extremities. It is, and it gives us a reasonable resolution. Now, in arthrography, it's very important that you can inject gadolinium, either intravenously or directly, and it will tell you more about the lesion. But you have to know that gadolinium should not be given to patients who have an elevated creatinine because it injures the kidney. Okay, we use a lot of contrast material in the shoulder and hip joints. What are the advantages? It gives us superior images of soft tissues such as ligaments, muscle, and fat. It can give tomographic images of the object of interest. It can be more effective than CT at detecting changes in intensity within the bone marrow to diagnose osteomyelitis, malignancy, and stress fracture. MRI contrast, gadolinium, is safer than iodine, but don't forget, in kidney disease, be very careful. So the disadvantages of MRI, it's prone to large and more severe types of artifacts from metal and motion. We know that if we have spine surgery with instrumentation, then it's really quite difficult to do an MRI. Metal screws or pellets can produce significant artifacts, obscuring anatomic structures. Metal suppression sequences can be used, but with loss of resolution. It usually takes longer than CT, and patients need to remain still throughout the scanning process. And in children, if you want to do an MRI, you need to sedate them. Some might do well with chloral hydrate, while others need general anesthesia. What are the dangers? I want to tell you a brief story. I needed an MRI of my spine. I had back pain. I came into the MRI room. The technician told me, only you need to remove your shirt and undershirt. Fine. My iPhone was in my back pocket. As I was having the MRI, I felt that I had a big blow on my hind, and then suddenly my pants tore and my iPhone came out of my pocket and went up to the ceiling and hit the ceiling. If you have a large magnet, this can happen. يا جماعة إذا عم تعملوا MRI على مريض وجيتوا على الX-ray room, don't go into the room if you have metals in your pocket. You can injure yourself. Don't go into the room if you have a foreign body in your body, because these can change position and you can harm yourself. Don't move in the room. Don't go into the room if you have particles in your eye. This can cause you to have blindness. Don't go into the room if you have some particle or shrapnel in your brain, because this can change position and you can die. This all arises because of the strong magnet in the scanner. You have to take extreme caution is needed when a patient, physician, nurse, or technician enters the room. I've noticed that many centers don't even put this warning on the door. I nearly killed the technician when what happened. I lost my phone. He wasn't able to pay me for it, but I nearly boxed him and killed him. He should have let me know. But it's nice to know this. It's nice to realize that this. Metal objects. Mifi. Metal objects brought into the scanner can turn into dangerous projectiles. Metal foreign bodies within the eye or brain migrate and cause blindness and brain damage. Patients with metal implants in their joints or body can have a MRI scan if the implants are secure in bone or stable. Discussion with the physician and the technician before the scan is important to avoid potentially disastrous outcomes. In pregnant women, although MRI does not use radiation, the effect of radio frequency and magnetic field on the fetus is unknown. It is usually recommended that a pregnant woman not have an MRI scan. Use of gadolinium as contrast. Gadolinium behaves like iodinated contrast media, accumulating in highly vascular and metabolic active tissues. It should not be administered to patients with a high creatinine because it can lead to nephrogenic fibrosing dermopathy. Ultrasonography. We use ultrasonography. We can use it in the shoulder. It helps us in rotate the cuff tears. We use it in the hip, in newborns, where we don't have solid structures, and in a child which we don't like to have him have radiation. It gives us measurements that lets us judge whether a dislocation is present or subluxation. There are certain angles, the alpha, the beta angle, which tells us about subluxation or dysplasia of the hip. You also can have static and dynamic ultrasound. And with the help of a transducer, you can do all the measurements. It also helps when you have an iliopsoas bursitis. It can identify it as it is present in the pelvic brim and it's causing pain. Ultrasound will help you in getting a diagnosis. In the knee, determination of articular cartilage thickness and identification of intra-articular fluid. It helps in soft tissue masses, hematomas, tendon ruptures, abscesses, foreign body location, and intraspinal disorders in infants. What are the advantages? It's non-invasive at the frequency used for diagnostic imaging. It's commonly used for imaging in children and pregnant women. It shows non-ossified structures, such as the femoral head, to diagnose hip dysplasia and dislocation. The equipment is portable and inexpensive when compared to MRI and CT equipment. It is highly echogenic structures, such as foreign body. Let us speak about glass. If you have glass in, you cannot identify it by a plain radiograph. Being that it detects highly echogenic structures, you can use it to remove that loose body, that particle. It can be used for targeting therapy, such as injections, ablations. You can use it even for taking biopsies. It's useful for injections and aspirations of fluid collections. What are the disadvantages? The image quality and interpretation depend on the experience of the ultrasonographer and radiologist. Diagnosing a hip dysplasia depends on the experience of the ultrasonographer. It needs experience, it needs time to learn it. You cannot image inside bone because bone cortex reflects almost all sound waves. Internal joint structures are not well visualized. Nuclear medicine, which is the last out of all these. A bone scan, medium 99, molybdenum phosphate complexes reflect increased blood flow and metabolism. They are absorbed on the hydroxyapatite crystals in bone. Areas of infection, trauma, and neoplasia are quite well detected by it, but the resolution is not that good. Whole body views gives us exist, and you can have pinhole views. It is good in detecting subtle fractures. In avascular necrosis, it tells us whether it exists by being hypoperfused to the area. It has an increased uptake in the reparative phase of avascular necrosis. It is excellent in detecting osteomyelitis, especially by using the triple phase study. Also in conjunction with gallium and indium scans. These are radioactive substances that we use. Total hip arthroplasty and total knee arthroplasty is helped by letting us know whether loosening has occurred or not. It helps in the femoral components, whether they are loose secondary to infection or not. In conjunction with gallium scan, it helps in infection. In jumper's knee, it helps by telling us whether the infrapatellar tendon is associated with an increased uptake. Osteochondritis dissecans of the talus can be located. What are the phase studies? The 3 phase studies, you should know them. And they help us also in reflex sympathetic dystrophy and osteomyelitis. The most reliable test is for non-displaced fractures of the scaphoid. What is the 3 phase study? The first phase is when you inject this radioactive pharmaceutical and the blood flow goes to the area. It is the arterial phase. The second phase is the pooling phase, the venous phase, which occurs 30 minutes later. And finally, the third phase, which we take after 4 hours, and this is the final localized area. Gallium scans are excellent for infections, but it is different in many ways from the technetium molybdenum phosphate. It depends on the serum proteins, and when you inject it, it goes to the area and you can detect cellulitis and osteomyelitis. Indium-111 is excellent, but the problem is you cannot have a result before 24 hours. Why? Because you incubate the white blood cells with indium, and that's after collecting blood from the patient. And you separate the leukocytes. Then you incubate it with indium-111. Then you re-inject it. And this goes to the area of inflammation. All these are used in infections, osteomyelitis, and total joint arthroplasty infections. Briefly about single photon emission tomography. I'm going to be very, the single photon emission computed tomography is a medical imaging technique that is based on conventional nuclear medicine imaging and tomographic reconstruction method. The images reflect functional information about patients, similar to that obtained with positron emission tomography. Single photon emission tomography is scintigraphy with CT to evaluate overlapping structures. It helps in evaluating head osteonecrosis. It helps in evaluating patellofemoral syndrome or jumper syndrome. And last but not least, spondylolysis. Uses of radioisotope label biologic active drugs. The radioactive tracer is administered to the patient to serve as markers of biologic activity. The images produced by scintigraphy are a collection of the radiation emissions from the isotope. So you use CT with the radiation isotopes. The isotopes localize, then you do a CT scan of the area. So the bone scintigraphy, bone scan phases most often use diphosphonate labeled with the radioactive technetium-99 phosphate. The initial transient phase is characterized by tracer delivery to the tissue, which represents the perfusion images. The second blood pool phase follows the initial phase. The final delayed phase shows tracer accumulation in the tissues with active turnover of phosphate, mostly in bone undergoing growth and turnover. These are the three phases we use in whether technetium, whether other radioactive substances are used. But the difference is one is transferred by means of proteins, the other means of diphosphonates occurring. What about positron emission tomography? Just to tell you, it uses a fluorodeoxyglucose, which follows the same function of glycogen or glucose as it goes into the tissues. And if you have a tissue which is malignancy, which is active and producing, and it's such an active metabolic activity, it goes into it just like glucose. That what happens is you have the 18-fluorine taken by the osteoblastic lesions is up to 10 times higher than the uptake of normal bone, leading to excellent image contrast. It helps in metastasis. So how do we do it? A positron emission tomography uses a metabolic tracer, FDG. And this is used very widely in clinical oncology. Fluorine deoxyglucose accumulation reflects the rate of glucose utilization in the tissue. Fluorine deoxyglucose is transported into the tissue by the same mechanism of glucose transport and is trapped in the tissue as fluorine deoxyglucose 6-phosphate. Use of fluorine deoxyglucose in evaluation of the musculoskeletal system is based on an increased glycolytic rate in pathologic tissues. High-grade malignancies tend to have higher rates of glycolysis than low-grade malignancies and have greater uptake of fluorine deoxyglucose than do low-grade or benign lesions. What are the advantages? Scintigraphy has a high sensitivity for bone pathology. Scintigraphy allows imaging of metabolic activity. Most metabolic processes involving bone have slow metabolic activity compared with that of soft tissue. So It is more effective in soft tissue than bone, but it does occur in bone, such as kidney and liver. These are very active, but fortunately, most radioisotopes are relatively long-lived and can be taken up by bone. So you have to keep this in mind. White cell scintigraphy can be used to diagnose osteomyelitis, as I spoke about gallium and indium-111. Scintigraphy can be used to diagnose metastases, stress fractures, or occult fractures. What is the disadvantage? They lack of detail and spatial resolution. It has limited early sensitivity to detect acute fractures in patients with slow bone metabolism. As you recall, I mentioned that bone, the metabolism is slow. In the liver and kidney, it's fast. For it to be absorbed by bone, it would take time. And therefore, these are diagnosed, but with time. It takes several days. Low sensitivity can occur with lytic diseases such as multiple myeloma. We know that these are negative on multiple myeloma, unless there is an area of bone formation. We know that scintigraphy has an affinity for increased blood flow and for immature bone formation. Scintigraphy has a low specificity for bone pathology. What about this? I want you all to listen. Radiation safety. Children and fetuses are especially susceptible to ionizing radiation. Radiography, CT, and bone scintigraphy produce ions that can deposit energy to organs and tissues. The energy can damage the DNA. Radiation for radioactive labeled traces in scintigraphy primarily affects the patient. Some traces, namely iodine-131, have half-lives of several days and can concentrate in the excreted body fluid and breast milk. Rapidly dividing tissues are the most susceptible to radiation-induced neoplasia. Bone marrow, breast tissue, gastrointestinal mucosa, gonads, lymphatic tissue, and the risk of cancer is approximately 4% per sievert, 100 rams. This is just to tell you the effect of radiation on tissue. You have to look at this table and see how much it affects in the brain. If you have 50 to 100 Gs in one dose, cerebral edema, and this can lead to death. What about fetus malformation? This 1-year-old child who had a CT scan, the fetal effect is greatest in the first trimester with doses of greater than 0.1 Gs, 10 rads. Late in pregnancy, greater or equal to 150 days post-conception. The greatest risk is an increase in childhood malignancies such as leukemia. 10 milli-G, 1 rad dose increases childhood leukemia risk as much as 40%. It is important to ensure that the patient is not pregnant when obtaining an imaging examination other than ultrasonography. Sensitive organs such as gonads should be shielded. Please tell your technicians. It is best to follow the principle of ALARA, as low as reasonably achievable. Dosing for pregnant women and children exposure to radiation decreases as an inverse square of the distance from the source. The farther one is, the better it is. Medical personnel should wear lead aprons and be monitored using devices such as film badges. CT delivers the highest amount of radiation dose among all medical imaging procedures. In conclusion, for this section, all clinical MRI scans image the protons in hydrogen atoms. It is extremely important to screen patients with metallic objects before entering the MRI machine. Ferromagnetic objects in or on the body can be pulled toward the magnet and cause serious injuries, like happened with my iPhone. Patients with advanced kidney failure should not receive gadolinium containing contrast agents because exposure to the agent can cause development of nephrogenic fibrosing dermopathy. A lower frequency ultrasound beam has a longer wavelength and less resolution, but deeper penetration. A higher frequency ultrasound beam can give higher resolution for superficial structures such as tendons and ligaments. Caution is advised when ordering nuclear medicine tests. For women who are breastfeeding, some of the pharmaceuticals can pass into the mother's milk and subsequently into the child. Exposure to radiation decreases as an inverse square of the distance from the source. And don't forget, please, that CT delivers the highest radiation dosage of all imaging studies. The risk of cancer is approximately 4% perceivable, and it is important to ensure that the patient is not pregnant when obtaining any imaging examination other than ultrasonography. And performance of other types of imaging examinations can be discussed in consultation with the radiologist and physician. Now we come to another section. This section is mainly a clinical presentation. Are there any questions?
Okay, Doctor.
Khalid, am I clear?
Yes, very clear, Doctor. There is some questions. I think one colleague he want to ask. Yeah. He want to ask about dynamic MRI.
Dynamic MRI.
Yeah.
Let me tell you. His question is very nice and very good. But dynamic MRI is not very new, but we really need it in orthopedics. We really need it. And it is used to evaluate instability. What do I mean by instability? We use it a lot in the spine. When we have an unstable vertebra slipping on the other, we ask the patient to do a dynamic MRI inflection and extension. This is something which is important. Anything where you need movement in association with diagnosis, dynamic MRI is excellent. But it gives us less resolution. But Mansoul has, not all centers have it. And that's it. Did I give you the answer?
Okay.
Another thing I did not mention about is EOS.
دكتور جون لو سمحت عندي سؤال.
ولك يا أهلا شو؟
For the previous section, you talk about the implant hardware and use with MRI should be discussed with surgeon and can be used with the percussion and if it is stable.
ما بسمع. شو؟ ما بسمع. خالد فيك ترجع تعيد لي إياهم؟
دكتور جون، الدكتور هو بيسأل يعني أنت ذكرت الكونترا إنديكيشن للMRI من ضمنها الهاردوير يوز.
Yes.
يعني what is the extent of using hardware in this case and
يا خيي, the problem with hardware is that with MRI, first of all, if it's very dangerous if you have, for instance, a metal in the soft tissue, or if you have a metal in the spine. If you use an MRI, these can change position. At times, it can go to vital areas, and you can harm your patient or even kill the patient. Now, I'll tell you, I do spine surgery. And the fact that I do spine surgery, let me tell you, one of our difficult, in spite of using titanium, where they claim that MRI you can do, we're having a lot of interference. And there are means in which we can remove the interference to some degree, but it decreases the resolution. سمعت شو خالد عم جرب اقول له اياها. It decreases the resolution.
Yes.
Okay?
Okay.
Electrical optical. بعد في شيء سؤال؟ يلا خليني.
لا ما في سؤال، بس إذا أنت يعني بتكمل.
طبعا بكمل، صوتي بعده منيح.
أي جدا. Okay.
Now about the imaging modalities that we spoke are MRI, CT, nuclear medicine, bone scan, gallium scan, and white blood cell PET scan. Now we're going to use certain cases. Some are taken from Miller, but I will tell you not all. Quite a number I have gotten them. Okay, but to give you an idea about what we're speaking. Let us take this MRI imaging. It's a T1 sequence. What can we identify in it, and how can we say that it's a T1 sequence? طلعوا بالmarrow, طلعوا بالproximal humerus. You see that it's bright. It means that fat is present and it's bright. What gives you a bright image? T1 gives you a bright image. You see that there's a zone of calcification at the site of insertion of the rotator cuff. This is black. This is the way we identify it. Look at the rotator cuff. The muscle, it's gray. This is present in both T1 and T2. The fiber structures are black. You see them at the articulation. You see them around the ligaments. And fat is bright. So that's why I'm telling you, throughout my lecture, you have to memorize which is black, which is white and bright. And this will tell you, what about the fluid? There's no fluid there. Look at the joint. There's no brightness. Therefore, this is a T1. So this is the way you identify a T1 image. T2. This is the same case, T2. Look at the joint. You begin to see that there is a bright area. This is T2 because we know fluid is bright on T2. Look at the proximal humerus. There is no fat. No fat. At times we use with T2 fat saturation. It increases the brightness. But what is present? Muscle. It's gray. It's present in both to be gray. Calcium is dark. So you have to know these, please. Please know it. We know that I stressed this, and I will tell you it again. Computed axial tomography tells us about occult fractures. This helps us. Tells us in complex fractures, mainly in the spine, axis spine. Ask me because I'm a spine surgeon and I get fractures. I want to describe which type of fracture. I want to describe the stability. Of course, ligaments are best described by MRI. Nerves are better described by MRI. But each one has its purpose. Intra-articular fractures, my goodness. I treat acetabular fractures. You don't realize how much CT scan helped us. I'm a fellow who has 50 years of experience. When I first started, there was no MRI, no CT scan. We had to depend on X-rays. When CT scans were discovered, our life has become much easier. It tells us about the intra-articular structures. It tells us about the joint congruity. It tells us about so many things. If you look at the calcaneus, when it's comminuted, it describes it much better. So please keep this in mind. Nuclear medicine, don't forget, it's a good screening tool. It can screen the whole skeleton, but it doesn't give us a detail on the anatomy. Its indications are for radiographically occult lesions and orthopedic infections. Yeah, Shabib, I put this slide up. Don't forget it. Never forget it. What does nuclear medicine also help us? We know nowadays sports has become very popular. We have runners, we have marathon runners, we have etc. All these interfere with the remodeling of bone, where the load on the bone is much more than the time for remodeling. As a result, you end up having a stress fracture, as has occurred in this patient. A bone scan has a sensitivity nearly 100%, while many times you cannot identify it on a radiograph. Look at the radiograph. There's no stress fracture. This is the same time the radiograph was taken, and you see that you have a stress fracture. So it's very important. Another important point, I want to warn you. When you have a stress fracture, you have to make sure it's a stress fracture. When you have an osteosarcoma, you have to make sure it's an osteosarcoma. I recall when I was in training in my university center, a patient was diagnosed to have an osteosarcoma. And at that time, we didn't have limb sparing procedures. We had amputations. The extremity was amputated. Why? Because the pathologist on biopsy said that this is an osteosarcoma. When the extremity was amputated and sent to the pathology, they went out of their mind. They said they made a mistake and it's a stress fracture, not an osteosarcoma. At that time, the patient's family raised a lawsuit against the hospital for $1 million, and they won it. But the sad part is the patient ended up without an extremity. So you have to pay attention. This is what I was meaning about the three phases. The arterial phase, where you inject the radioactive substance. Then you have the blood phase, where you have pooling of blood. This is done, taken 30 minutes later, and you see where the accumulation is most. In this case, it's the right side. And then after 4 hours, you have the retained amount of dye, which occurs at the site of the problem. In this case, it was a fracture of the scaphoid bone. SPECT scan. This is a single photon emission computerized tomography. I use it a lot in the spine. Why? Because many times we have cases of spondylolysis that we cannot demonstrate, not by plain X-ray, not by computers, not by etc. So we have to inject a radioactive substance, let it arrive at the area of the activity. You see nowadays ballet dances, sports, various sports where you have hyperextension injuries, they can have a fracture through the pars interarticularis, which is not apparent. When you use a radioactive substance with a CT scan, the radioactive substance localizes over there, and then you do a CT scan and you can identify it. And this was what happened in this case. You see, this is a coronal section on CT scan showing an increased uptake, and this is a sagittal cut, likewise showing an increased uptake, telling us that the problem is in the posterior column. And then finally, an oblique CT scan was taken, an axial CT scan was taken or oblique, which showed the defect to be in the pars interarticularis. So if you ever are asked a question on spondylolysis, how would you demonstrate it most accurately is by a single photon emission computerized tomography. So keep this in mind. You have to keep in mind that nuclear medicine or radioactive substances don't have an affinity for lytic lesions, as in this case, it was negative. So for this reason, if you do use a nuclear medicine scan or inject in a patient with multiple myeloma, at times you'll have negative findings. Why? Because it's purely lytic. So you have to keep this in mind, fellows. So nuclear medicine, you have to keep in mind it's ideal for orthopedic infections, especially when no surgery is done. Yani, if you use a scan in a patient who has had surgery and had a total hip several years ago, it will help you. But if you're using it for acute phases, as Parvisi repeatedly says, it's not helpful. Labeled white blood cells also are helpful. And you can use it in recent surgery or trauma. With gallium-67, we can identify infections and discitis in the spine. So keep this in mind. Now, what about shoulder imaging? We can use plain X-rays, we can use CT scans, and we can use magnetic resonance. I want you to look at this for 10 seconds and look how a plain radiograph would tell you, how a CT scan will appear to tell you mainly about anatomy, about the bony anatomy, and an MRI would tell you about the soft tissues. Please don't forget this. This is a patient, let me tell you, this is quite common, and we love to ask this in the oral exam. This is a patient who is a weightlifter. He lifts all the time, and he complained of pain in one of his shoulders. On plain X-ray, this was the result. There was an increase in the gap between the acromion and the clavicle. And what this patient had is a condition which we call osteolysis of the outer end of the clavicle, which occurs mainly in weightlifting. So to prove this further, an MRI was done, and you can see the increased fluid, you can see the increased inflammation, and you can see that there is a high T2 signal intensity. So keep this in mind. Osteolysis of the distal clavicle occurs in patients who are weightlifters. This is a young individual, 20 years old, who came presenting with this problem. He had prominence underneath the acromion. He had the gap beneath it and fullness anteriorly. And this patient ended up having an anterior dislocation of the shoulder. If you notice, after reduction, there is a defect on the upper superior outer aspect of the head. And this is what we call a Hill-Sachs lesion. This is secondary to impingement of the head on the antero-inferior aspect of the glenoid. This shows it more, and the best way you can demonstrate it is by doing a swimmer's view or auxiliary view. Some demonstrate it with the striker notch view, but you have to know these views. You have to know the auxiliary view, the striker notch view, the true AP view of the scapula. You have to know West Point view, how to do it. You have to know these because we will ask this in the exam. I'm not going to give it to you now. And this is not the subject of this section. This shows you how this patient developed a Hill-Sachs lesion, which is a defect due to impingement of the upper end of the humeral head on the antero-inferior aspect of the glenoid. You see the head over here. I don't know whether my pointer will show it. You see it impinging on the antero-inferior aspect of the glenoid, and as a result, you get an erosion of bone. So, this is a normal MRI. You have to get used to how it looks with the anterior posterior labrum. You should know. You should know on an axial cut how it appears. You have to know that the labrum surrounds the edges of the glenoid. It's triangular in shape. At the superior margin of the labrum, the long head of the biceps is attached. And the labrum, if you look at the pointers, comes out from both edges all around to create a larger surface for the head. If you look at the head, it's much larger than the glenoid. And it helps in creating a negative phenomena and keeping the head in place. So keep this in mind. And in your practice. The Hill-Sachs lesion, as I mentioned, is impaction of the humeral head against the antero-inferior glenoid, and it's associated with a Bankart lesion. What is a Bankart lesion? It's an avulsion of the capsule and a fragment of bone at times from the anterior inferior aspect of the glenoid. This is an MRI showing a large Hill-Sachs lesion. And you see it on CT scan on the right-hand side. It's a defect. Don't forget it. In anterior displacement, you see it, dislocation, with tears and avulsion of the glenoid inferior. Let us look at the coronal plane. You see over here the superior labrum. If there was a tear of the superior labrum, you see that when you inject a contrast, it will go through it. الله شو صار هلا؟ نزلت هيديك ما بدي اياها. Okay. Now let's go back. Okay. And you see that the labrum is triangular in shape, and it is more prominent on the dorsal aspect or the superior aspect. You see, this is an intact labrum on a coronal view. If you see on the left side is what I showed you before, and on the right side, you get a tear of the superior labrum. And this is what we call a slap lesion, a slap lesion. At times, this tear can be associated with a tear of the long head of the biceps. Okay. What about posterior dislocation? I'll tell you, many of us miss a posterior dislocation because we don't take proper x-rays. We don't take true anterior posterior x-rays of the shoulder. You can see that there's an overlap on the plain x-ray of the glenoid with respect to the head. If the patient comes to you with an externally rotated shoulder, then think of an anterior dislocation. If the patient comes to you with an internally affixed shoulder with a dislocation, then you should think of a posterior dislocation. It is usually locked in internal rotation, and this is the most reliable sign. Don't ever forget this. And over here you have another x-ray with a milder one. So pay attention to this. Posterior dislocations can be subclassified into 3 anatomic types based on the final resting portion of the humeral head. It can be subacromial. This is the most common. It can be subglenoid or subspinous. The whole head comes and lies beneath the spine of the scapula. Posterior dislocations usually result in the humeral head being posterior to the glenoid and inferior to the acromion. This shows you diagrammatically. On the left side, you see a posterior dislocation, and in the same slide, you see the head impinging on the posterior aspect of the glenoid instead of the anterior aspect, and it's causing a Hill-Sachs lesion. This time, the Hill-Sachs lesion is not superior, it's central, and you have to keep this in mind, okay? This is on the right-hand side. It is a diagram showing you a posterior dislocation and the glenoid lying in front. These, you have to think with a posterior dislocation, you can have a labral lesion. Instead of having it in the superior, you'll have it posterior, and the blue arrow points to the defect seen as the posterior Bankart lesion, the reversed Bankart lesion. It's a labral tear, and this you should keep in mind. So in posterior dislocations, you have a posterior labral tear, you have a Hill-Sachs lesion, which is in the center of the head, not on the superior aspect. It is most commonly caused by a fall onto the arm or a direct blow, a rugby tackle. It is also seen in people who do a lot of throwing. The glenoid has a rim of tissue, the labrum, around its edge. At the top of this rim, 12 o'clock, the biceps tendon also attaches. Keep this in mind. This shows you the posterior labral lesion and the Hill-Sachs lesion. The Hill-Sachs is present in the center of the head, not in the superior aspect. So keep this. This is a reverse Hill-Sachs lesion. In the young shoulder, the labrum plays an important role in keeping the shoulder joint stable and in a proper position. When a labral tear is causing a shoulder dislocation, surgery may be necessary. At the age of 40 and above, surgery is rarely needed for labral tears due to wear and tear. Now let us come to rotator cuff imaging. This is a plain shoulder. What do you think is over here? There is a rotator cuff there. Why? Look at the head. Where is it with respect to the glenoid? It is proximally displaced and impinging on the acromion. With time, we call this acetabularization of the acromion. So this, on plain X-ray, you can tell this. It tells you whether it's acute or chronic, because chronic cases migrate gradually, proximally. So plain radiography of the shoulder can be very helpful in the diagnosis of rotator cuff disease. Standard views should include a true, I repeat, a true anterior posterior view in the plane of the scapula, a supraspinatus outlet view, and an axillary view. Now, what about rotator cuff imaging? On the left-hand side, we know that the rotator cuff is dark on both T1 and T2 sequences. Don't forget this. This is very important. What about tendinopathy? Not tears, tendinopathy. You have an intermediate signal on T1 and T2. تشعر اللون الأبيض. This tells you that there are some micro tears with inflammation. And this is how it would look on a patient on the right-hand side. This shows you a tendinopathy, but on the left side, okay? But on the right side, you should distinguish it from calcification. A calcific bursitis appears dark completely. There are now white streaks, as we see on the left side. This is how we distinguish between the two. Calcification is dark throughout. On the left side, we see streaks. Don't forget this. Over here, we have a complete tear of the rotator cuff. And we see that there is fluid, and this is bright on T2. And this tells you that there is a tear. And this tear can migrate mesially. According to degrees, there are classifications, okay? Now, on T1, you can tell, even if you don't have a tear, you can tell whether there is fat infiltration of the rotator cuff. This is very important for us because the amount of fat infiltration tells us whether, if we repair the rotator cuff, whether we can have a healing or not, or whether it would rupture later on in life. Besides, on MRI, we can see the middle glenohumeral ligament, which originates from the superior glenoid tubercle. It courses obliquely, superficial to the anterior labrum, and blends with the deep fibers of the subscapularis. This is a normal finding. If you look diagrammatically below, you can see it. It's thick than the other ligaments. This is the middle glenohumeral ligament. It helps in stability of the shoulder joint. What we mean, we like to ask, what is the Budford complex? The Budford complex is a normal anatomic variant, and we see that the middle glenohumeral ligament is thick. So don't confuse this with the tear. What's a Hagel lesion? On the left side, you see a normal inferior glenohumeral ligament, which is intact. On the right side, you see that there is a grayish appearance on T2, suggesting that the inferior glenohumeral ligament is torn. This is a rupture of the inferior glenohumeral ligament of the shoulder. Humeral avulsion of the glenohumeral ligament, Hagel, is an injury to the inferior glenohumeral ligament, causing instability and or pain, and a missed cause of recurrent shoulder instability. What about the paralateral cyst? Paralateral cyst is when you get a cyst or ganglion in the superior or the subacromial area between the acromion and the upper margin of the glenoid. It's pointed out by the arrow. This gives us a problem because this can press on the suprascapular nerve and give a paralysis of the infraspinatus tendon, because the pressure passes the area in which the suprascapular nerve supplies the supraspinatus tendon. If we get this in the exam, don't mix up and say this is paralysis of both the supraspinatus and the infraspinatus tendon. It is only the infraspinatus. If the compression is at the entrance of the suprascapular nerve through a foramen at the superior margin, then if you have a ganglion or pressure over there, both can be paralyzed. The way we do, we can aspirate this. Mainly these are ganglia, and they can give us paralysis. This is how to show you the suprascapular nerve, how it's passing together in companion with the suprascapular artery. It's passing through a foramen, which is bounded by the scapular ligament. This is the superior transverse area through which the nerve and artery. The artery passes from outside while the nerve passes underneath. If this is under pressure over here, you can end up having paralysis of the suprascapular nerve to the supraspinatus and infraspinatus. If it is in the region of the notch, of the suprascapular notch, then it's only of the supraspinatus, of the infraspinatus muscle. Let us see it. Over here on MRI, you can see the cyst, and you can see how clear it is. You can see that there is an associated flap tear of the suprascapular notch. On the right-hand side, you can see that there is evidence of inflammation of the tendons. What is the most likely diagnosis over here? This is very clear. You see that the supraspinatus spinatus tendon has been completely avulsed. You see that the head is impinging on the acromioclavicular joint, and you have acetabularization of the humerus, the acromioclavicular joint, and you have a lot of fluid around the shoulder joint. This is a rupture. This patient has what? If you look over here, you see that there is fatty infiltration of the deltoid muscle. Even if you look at the teres major and minor, they're also infiltrated. And this is the problem with this patient. He had shoulder pain, and this is a T1. T1, you know that fat is bright, and this is what do you think happened here? You have a nerve that is passing through here, and it's passing through the quadrilateral foramen, which is bounded by the lateral trapezius, by the medial end of the humerus, and by the deltoid and the teres minor and teres major. And this is what we call the quadrilateral space syndrome. This shows you it. You see the teres minor over here. You see the infraspinatus. You see the nerve. The nerve is coming over here. This is to the scapula. It has nothing to do with it. The nerve is under pressure in this region, and it is the axillary nerve. So it refers to a rare condition in which neural and vascular structures are entrapped in the quadrilateral space. This space is created by the lateral head of the triceps, the teres minor, the teres major, and medial border of the humerus. Symptoms of quadrilateral space syndrome usually include vague shoulder pain, numbness, or tingling in the arm, and tenderness to pressure over the area of the quadrilateral space. A dull ache in the shoulder may worsen when the arm is moved overhead repeatedly. Weakness and instability can sometimes be noted. Let us say this is a case, MRI of a patient with shoulder weakness. What is the most likely diagnosis? This is a quadrilateral space syndrome, and the deltoid is affected. Why? Because it has fatty infiltration, and it is partially degenerated, and the teres minor, being that it's supplied by the nerve, the axillary nerve. So both the deltoid and teres minor. Let's come to case 3. This is a radiograph and MRI of a 40-year-old man who reports gradual onset of shoulder pain. What is the most likely diagnosis? We all know that this is osteonecrosis. And there is the double column sign. You see that there is a nearly whitish or gray curve with respect to a black curve. And you see that there is a zone of necrosis. This is best seen on T2 and consists of 2 serpentine lines. The inner bright line represents the reparative granulation tissue and an outer dark line. And that's why we call it the double column line. And this represents as an adjacent dark line. The outer line is always continuous, while the inner line can be discontinuous or absent secondary to repair the process. So the diagnosis is the double line sign and avascular necrosis. This is a 26-year-old with severe progressive shoulder pain, 2 years following arthroscopic assisted banker repair and thermal capsulorrhaphy. We know that thermal capsulorrhaphy has given us several problems. Now, after 2 years, the patient comes complaining of pain. And you can see preoperatively, you see that the articulation is not bad on the left side, but it becomes irregular in the central view and completely narrowed in the lateral view. And this patient had ended up secondary to thermal capsulorrhaphy to have chondrolysis of the glenohumeral joint. This is damage to the cartilage of the shoulder joint. Enough for the shoulder. ناخد راحة ونفوت بالقلبه. اوكي خالد؟
اوكي دكتور.
كيف مبسوطين؟ ان شاء الله مبسوطين. لا عم
جدا
ضيع
مبسوطين. تسلم دكتور. كلهم مبسوطين.
بدنا علامات منيحة يا خالد.
هلا بيسمعوا الجماعة كلهم وإن شاء الله يبيضوا وجهك ووجهنا يعني.
بدي إياهم يقدموا فحص، بدك تقدم الفحص هلا، لأن this is something to memorize, something to study, and then please consider the grades they get.
Yeah.
Even for the young chap who I think I know, يلي دايما بفرجيني صورته, that I examined in the board exam. We don't want him to forget. We not want him to always learn new. خليني لكم شغلة، مع انه انا مفروض ارتاح هلا، خليني لكم. Why do we have repeated board exams in the United States? The whole purpose is to keep people up to date, to keep people knowledgeable, because من سوء الحظ في كتار بياخدوا شهاداتهم وما بيقعدوا بيفتحوا كتير. اوكي؟
اوكي دكتور.
يلا هلا برتاح انا دقيقتين.
ارتاح. اوكي.
I know it's a very long lecture, but the whole thing I thought about was people coming to the exams this time. I want them to have a general idea and to help them in the reviewing for the exam. إن شاء الله بكرة قريبا بتروق عنكم ونقدر نعمل الفحص البورد عنكم شي مرة.
ان شاء الله دكتور ان شاء الله. انا اسال. سلام.
في شي اسئله؟
دكتور في سؤال واحد من الزملاء طرح انه about the children MRI, the limitations in relation to the age and repetitive taking for some neoplasms, for example.
مشين شو ما فهمت.
يعني children MRI uses, what is the limitation?
In children like it.
What is the age limitation and the repetition?
Let me tell you. The main disadvantage of MRI in children is that we have to put them to sleep. Now, to have a good MRI, they have to be still. And to be still, they have to be still for 20 to 30 minutes. And you can't imagine how disturbing for a child are these noises that come out as the magnetic field is forcing the hydrogen ion to show us the image. But I think it's quite disturbing. You have to put them to sleep. Now, I don't really think it's harmful to a child. Why? Because there is no radiation whatsoever, no radiation. But in general, don't ask for it unless you really need it. The problem is with CT scan if you use it on a child. It has the highest amount of radiation, and the child's tissue is immature, and the DNA in it responds most highly to the radiation. As a result, there is a high incidence of malignancies depending on the amount of rads given. So you have to pay attention to this. Am I clear, Khalid?
Okay, clear. Thank you.
Okay, let's start.
Okay.
We're coming to the elbow. This is a patient. خلينا نشرب شوي. This is a patient who likes to do weightlifting and all sorts of sports. He began to feel that there was a mass in the anterior aspect of his arm. If you look, this is a lateral view, a plain X-ray of the arm. You see that there is something which is fuzzy at the junction of the middle and distal third of the arm in the anterior aspect. But this is not sufficient. So, with time, the previous X-ray was missed. With time, this patient had this lesion. Now, and this patient, if you see that there is sclerosis at the outer end, and the activity of the lesion is in the center. Whenever you see such a lesion with sclerosis at the outer end, and it's healing from outside to inside, this is heterotopic ossification or myositis ossificans. There are 3 regions pathologically, and I would tell you, look it up, of heterotopic ossification. 3 phases. Phase 1 is the outer, phase 2, and phase 3. This is an MRI. If you look at the MRI on the left-hand side, you see that you cannot tell the difference between this and the muscle tissue. If you look at T2 due to the fluid and the inflammation, you can identify it. Okay? Now, this is a sagittal cut. You see that the sclerosis is at the end, and inside you have the activity, but there is a lot of inflammation going on. Now, we compare this. This is the CT scan on the same patient. We said that at the previous part of the lecture that MRI won't demonstrate the cortex and the trabeculae very well. A CT scan was done, and you see the amount of sclerosis over here, which tells you that this is a myositis ossificans or heterotopic ossification, which is maturing. Myositis ossificans can occur by other means. It's quite common to occur. We see it quite often, especially in sports when they have trauma and they have a mass or hardening of the tissue. The most important is to distinguish it from a soft tissue tumor, but the most important is that it is juxtaposed to bone and is surrounded by sclerosis. Usually, a tumor grows centripetally and centrifugally. One grows from the outside, while benign lesions grow to the inside. This is a patient who has had trauma of the elbow and has myositis ossificans. This can occur with posterior dislocation of the elbow. And in addition, you can have falls on the extended elbow, and you can have various types of fractures. You have to identify them. Over here in children, one of the descriptions that we like to ask about is the sail sign, where following a fall, there is hematoma. Hematoma will push the fat both anteriorly and posteriorly, and it would appear like a sail. So you have a fall, you have a hematoma, you have fat, which is normally present anteriorly and posteriorly, more so anteriorly, but this fat is pushed anteriorly by the hematoma and posteriorly by the hematoma. And that's why it gives you a sail sign. It becomes more prominent. You have to pay attention for fractures of the head of the radius. They show a fracture line is dark on T1 and dark or fluid signal on T2. Pay attention to this. This is the head of the radius. You have to pay attention to falls in children where you can get an avulsion of the medial epicondyle, and on valgus deviation, the fragment might go into the joint, as is pointed out by the red arrows on the right-hand side. This is an indication that you need to operate. If it's not in the joint, a question we ask, should we operate or not? If it's less than 1 centimeter, you don't need to operate. If it's more than 1 centimeter, you do. This is how we like to reduce it, trying an attempted close reduction, is to increase the valgus on the elbow to get the fragment out of the joint. What about the lateral ulnar collateral ligament disruption? The ulnar collateral ligament may also be injured due to falls on the outstretched arm. In this case, the ulnar collateral lateral ligament may rupture or get pulled off the humerus, chipping a small piece of bone, leading to avulsion of avulsion fracture. And this would show it on the stress view. Now, over here, you see the whole forearm is displaced laterally, but you see that there's an increased signal over here, and this can be an ulnar lateral collateral ligament rupture. Okay, lateral ulnar collateral ligament rupture. Sorry, I'm wrong over here. This is the lateral ulnar collateral rupture, and you have the ulnar lateral collateral ligament. You have the lateral ulnar collateral and the lateral. I think this slide is confusing. I apologize for it. Let me see over here. Let me see. This is a rupture of the ulnar lateral collateral ligament, a larger view. Biceps avulsions. This is helpful. I want to ask, I had the black line out throughout my lecture. Then suddenly it appeared black to overlap my lecture. ليه اجتني هلا؟ هيدي ديفو من عندكم يا جماعة. شو رأيك يا خالد؟
الدكتور عندنا ما بتظهر.
هيدا في عندي أنا جاي أسود على السكرين.
الدكتور جون عندنا ما بتظهر أبدا.
من عندكم لأن ما كان عندي إياه كل اللكشة هلا إجي ما بعرف.
الدكتور صلاح اشرح. في حاجة ظهرت.
شو؟
الآن يشوفوها الشباب دكتور. هم بيقولوا ما في شيء.
طيب اوكي نو بروبلم. هذه اللي بتقلي قديش في participants، اللي بتقلي في share او remote control annotate mute تجي على راس السكرين that covers my lecture notes. طيب ماشي الحال. Biceps tendon, we all know about it. There's the long and the short head. The short head is ruptured from its insertion on the radial tuberosity. And this occurs whenever a force occurs opposing to flexion of the elbow. And this can be detected on MRI and clinically. Clinically, the patient will have a bump on the anterior aspect of the forearm, and this is what we call a Popeye elbow, and it appears as such on the photograph, and you can see the avulsion over here. This tendon, of course, is involved in flexion and pronation. So for this reason, we like to repair this in young individuals. In older individuals, we depend on the brachialis muscle to take over. This shows you a distal biceps tendon rupture. Over here, you can repair it, put it back into the tibial tuberosity, and insert an interference screw with plus suture. And I don't depend fully on an interference screw. You can also very rarely have triceps ruptures, and we use the semitendinosis to repair it. This shows you a triceps rupture. Tennis elbow, we are all acquainted with it, inflammation of the common extensor origin. Mainly the extensor carpi radialis, brevis, and longus are involved. And this shows it. And also you can have the Gulfus elbow on the medial aspect. So keep this, and these are well demonstrated by MRI. Okay? So also you have to think of the medial collateral ligament, which can be ruptured over here on valgus injuries. This is what I was trying to explain at the beginning. And this shows you the ligament of how it's ruptured from the sublime tubercle. Another point is you have to pay attention. This is a question that we ask. You see that what is apparent on this MRI. We see a bunch of muscle with gray tissue. We see over here there's a slight fragment of bone. What do you see over here? That is where you see that there is an impingement injury between the head and the capitellum over here. You have to pay attention to this. This is an osteochondral. This is an osteochondral injury of the capitellum associated with valgus stress and common flexor tendon abnormality. Don't forget about Montesia fractures, and don't forget about the Bado classification into 4 types. هيدي يلعب لكم إياها تدرسوها. Don't forget about the Galeazzi fracture, which is at the distal third of the radius. So don't forget about this. Don't forget about fractures of the proximal radius with tears of the interosseous membrane. This is a normal interosseous membrane. This is a tear, the membrane which connects the radius and the ulna together. As a result, you have proximal migration of the radius, and you'll end up having a valgus deformity of the elbow and pain in the wrist. This is a patient who came presenting with pain in the wrist joint and on tenderness over the flexor carpi radialis. The patient had severe pain. And on MRI, you see that there's an increased signal intensity on axial images and also longitudinal images. And you can see that there is inflammation. And this patient turned out to have flexor carpi radialis longus tendinitis. Okay, so don't forget this. Don't forget about decurvent stenosynovitis, where it is inflammation of the first dorsal compartment of the wrist. You know that there are 2 muscles over there, and you have the extensor pollicis brevis and the abductor pollicis longus. These get inflamed through the tunnel sheath. And one of the examining signs is decurvence sign. We ask about it, you have to read. Don't forget about scapholunate disruption and the Terry Thomas sign, who was a famous English actor. The gap between the teeth, the scapholunate is torn. You can also have lunotriquetral tears. The best way to demonstrate it is by taking an X-ray, a fifth view. You see that there is a gap. Examination is done by means of the Watson test. You should know it. I don't have to go through it because this is not the lecture. This is the wrist view taken to show you the scapholunate dislocation or gap. This is in MRI showing it. Lunate dislocation. One of the differences we love to ask in exams, what is the difference between perilunate and lunate dislocation? Perilunate is where all the carpus dislocates with respect to the lunate. The lunate remains in good relation with the distal end of the radius. In lunate dislocation, the whole lunate dislocates into the space of Poirier and is away from the distal end of the radius and the rest of the carpal bones. Lunate dislocations typically occur in young adults with high energy trauma, resulting in loading of a dorsiflexed wrist. Overall, carpal dislocations comprise less than 10% of all wrist injuries. Lunate dislocations are far less common than the less severe perilunate dislocation. The lunate is displaced and rotated volarly, usually in the space which is less filled with tissues, but it can risk a carpal tunnel, acute carpal tunnel syndrome, and press on the median nerve. The rest of the carpal bones are in normal anatomic position in relation to the radius. These should not be confused with perilunate dislocations, in which the radiolunate articulation is preserved and the rest of the carpus is displayed. The mechanism of lunate dislocation typically occurred due to a fall on an outstretched hand or during a motor vehicle injury where there is a forceful dorsiflexion of the wrist. There is injury of all of the perilunate ligaments. Most significantly, this is a question I love to ask, most significantly, the dorsal radiolunate ligament. This shows you a lunate dislocation. You see, it appears like a triangular space. And on the lateral view, you see that the whole lunate is out of the distal end of the radius. This shows it further. And in the middle aspect, you see a perilunate dislocation. On the left, you see a lunate. In the center, you see a perilunate. And on the right-hand side, you see a lunate. So the lunate is present on the right side. This is to show you it further. A question is asked, how can you identify a lunate dislocation on a simple AP? If you look at the lunate on the AP, you see it's triangular in shape with respect to the rest of the carpal bones. And you see that there is a step between the scaphoid and the lunate, and the gap at the medial end or at the mesial end of the distal radius. What about ulnar impaction syndrome? It occurs from an ulnar positive deformity of the distal end of the ulna being longer than the distal end of the radius, and this impacts on two structures, the triangular fibrocartilage and on the lunate. You can see it on the X-ray on the right-hand side. So you have a positive ulnar variance. You can have perforation of the triangular fibrocartilage, which lies between the styloid process and the medial end of the distal end of the radius. This is eroded by the distal end of the ulna, and it erodes a portion of the lunate. You have a cartilage defect of the distal ulna and proximal lunate. You can see it on MRI very clearly. This is a positive ulnar variance with perforation of the triangular fibrocartilage. And you have subchondral cystic change. What about osteonecrosis of the proximal scaphoid and lunate? Osteonecrosis is one of the common complications of scaphoid fractures. Its incidence has been reported to be 10 to 15%, but approximately all patients with fracture involving the proximal fifth of the scaphoid progress to develop osteonecrosis. Osteonecrosis usually involves the proximal pole only. This is a fractured scaphoid. You see that there is an increased density of the proximal end of the scaphoid. The distal is intact, the vascular supply is intact, while proximally it is not intact. This shows it further. This goes to tell you that the vessels coming on the radial aspect, the radial artery, does not go all the way through the dorsal ridge to supply the proximal fragment, so it undergoes necrosis. By undergoing necrosis on plain X-rays, due to lack of remodeling of bone, it appears much more denser on plain X-rays than the distal fragment. Steinbock's disease. We have avascular necrosis of the lunate, and there is a Lechman classification that we always ask about it in the exam when we present a Steinbock's disease. And it's classified into 4 types. One is the normal apparent avascular necrosis with normal appearance of the lunate. 2 is an intact lunate, but there is sclerosis or increased density. 3A is a collapse of the lunate. There is no rotation of the scaphoid, because we know that when there is a collapse, it tells us that this collapse is early. There's no time for the lunate to rotate. And 3B is a collapse of the lunate with fixed rotation of the scaphoid. It indicates it's more chronic. Steinbock's disease is a condition where the blood supply to the carpal lunate is interrupted. Bone is living tissue that requires a regular supply of blood for nutrition or nourishment. This shows you Steinbock's disease in a 27-year-old male with ulnar-sided wrist pain. 3 months follow-up film of the wrist shows that there's an increased density. Okay. This shows you fragmentation, and then MRI is shown over here. Carpal tunnel syndrome, we all know about it. Can occur secondary to ganglia, secondary to any fractures, secondary to hypothyroidism, secondary to Sotos degenerating disease, secondary to any systemic disease like rheumatoid arthritis. They will have numbness in the lateral 3.5 fingers. This shows you this can be a ganglion causing pressure. Underneath the flexor retinaculum. And the treatment, of course, is the carpal tunnel release. What do we have here? This is a skier pole injury, meaning that this in people who killed rabbits by turning the head, there's a sudden twitch. There is an avulsion of the ulnar collateral ligament of the thumb. And what happens? This ulnar collateral ligament displaces in the opposite direction, and what lies between it and the reduction site is the adductor pollicis. And this we call a Steiner lesion. Now, if you notice, the ulnar collateral ligament is the ligament that supports the thumb during pinch. And so when this occurs, you have to repair it. You have to reduce it, put it, either pin it in place or put some few screws till it heals. This is what we call a Steiner lesion, avulsion of the ulnar collateral ligament of the proximal phalanx between the metacarpal and the proximal phalanx. We call it the skier's thumb, and they use the pole. As they're coming down, the pole gets stuck and they get an impaction injury on the area. A Steiner lesion occurs when a complete distal thumb ulnar collateral ligament tear results in the interposition of the aponeurosis of the adductor pollicis muscle between the metacarpal phalangeal joint and the torn ligament. Some collateral ligament injuries, most commonly the ulnar collateral, are athletic injuries and lead to a disease in effective thumb pinch and grasp. The diagnosis relies upon the thumb metacarpal phalangeal radio-ulnar stress exam and MRI studies. And the treatment involves an anatomic repair or reconstruction which reliably restores the essential function of the collateral ligament. What we have here, this shows it further, okay? What we have here is a typical mallet finger. We all know about it. It's a ball hitting the distal phalanx in flexion. When the extensors are pulling in the extension, it avulses a small fragment. What we have here, this is a volar plate avulsion, and this happens from extension, hyperextension injuries of the proximal interphalangeal joint. What is a jersey finger? Jersey finger means not New Jersey. A jersey finger is a shirt injury where لما بيلعبوا فوتبول واحد لحق الثاني وبيكمش الشيرت من ورا يصفي فيه force of flexion vs a forced extension. A flexion, the tendon, vs the extension of the force. And these two forces will create an avulsion of the flexor digitorum profundus tendon. Its name comes from football athletes who have grabbed or gripped the jersey يعني القميص of an opposing player who is trying to get away. And it most commonly involves the fourth finger. This is it. The fragment of bone moves proximally. It may stop at the PIP joint or the proximal interphalangeal joint, or at one time I had to remove it from the wrist. And it is the fourth finger, which is the most common cause. At times, we can get ruptures of the pulley system, and this occurs with forced extension, and we have bowstringing. The tendon doesn't stick to bone, it bowstrings with flexion. And this is common in rock climbers. What about the lower extremity? Hey, fellows, we're close to the finish, but I want to give everything to the fellows who are sitting for the board exam. This is a brief review course for me. Today, in one session, one long session, this is avascular necrosis. We spoke about it, and we spoke about T2 being the most accurate in diagnosis. We can know of it way before time. CT would quantitate the amount of necrosis, but not in the diagnosis. Another point we can use is many times we all receive patients coming to the emergency, falling on the hip, and we suspect an insufficiency fracture. Or on the other hand, patients who have no symptoms suddenly begin to have pain in the hip, and you suspect an insufficiency fracture. You will end up having a sclerotic line on the inferior aspect of the neck. Now, let me tell you something which is very important. We can have a stress fracture at the base of the neck, and we can have it higher up. It's very important to know that if you have it at the base, doesn't mean you should treat it conservatively. You can pin it, of course, but the incidence of displacement of the fracture is higher in high fractures, yani near to the head, near to the subcapital region. An MRI is best to demonstrate it, demonstrates a dark line on all pulse sequences. The line is incomplete. It is surrounded by edema. This shows you a more proximal one with displacement. This shows it further. We see it in the base, but not as frequent as occurs more proximally with displacement. There's a high risk for completion. Avulsion injuries of the pelvis. This is a schematic drawing of the pelvis. And what people to be examined, they have to know everything about the landmarks of the pelvis. They have to know where the sartorius originates from the anterior superior iliac spine. You have to know where the rectus femoris originates, from the inferior iliac spine. You have to know that the gluteus medius inserts on the greater trochanter. You have to know that the iliopsoas inserts on the lesser trochanter. You have to know about the hamstrings and the adductor magnus, where they originate from. You have to know about the pelvic brim of the pelvis, what muscle passes around it, what bursa is present over there. You have to know these. You have to know the iliopsoas, know about every structure of the hip anatomically. Now, we can have this is an entity that we call the hip pointer diagnosis. It's an avulsion of the iliac crest apophysis in adolescents. And it can occur secondary to falls, direct falls on the ilium, as is shown in the mid diagram. And these can occur in bilateral injuries, and the patient will point to it and say, ouch, I have pain over here. Many are not aware of it. Ask for an MRI and you see that there's an increased T2 signal intensity. I repeat, this is called the hip pointer lesion. This is an avulsion of the sartorius tendon of the anterior superior iliac spine. This happens when the muscle is contracting and the patient is in extension. This pulls out the bone. This shows you further sartorius while they are occurring in injuries. Look at the patient who's jumping. He's extending his hip. He is forcing his hip in extension. What attaches the sartorius is a two-joint muscle. It's attached to the tibia and what? The anterior superior iliac spine. When he's hyperextending, there's a force on the anterior superior iliac spine which fractures it. Don't forget about the anterior inferior iliac spine. You have the rectus femoris. Likewise, this can be avulsed and a fragment. Many times I've had patients refer to me thinking that it's a tumor, and I would tell them this is a avulsion of the rectus femoris from the anterior inferior iliac spine. So keep this in mind, fellows. What happens is many people, and I hope not you, forget to read about, and they think that there's a tumor or heterotopic ossification that is occurring here. Let me tell you, this has been an ancient rupture of the rectus femoris. You can confuse it, and it was confused with an echondroma or an osteochondroma. And the patient was followed up each year with x-rays, being that osteochondromas of the proximal end have a higher incidence of change into tumors. So you have to keep this in mind. You should not confuse this. You have to know that the rectus femoris arises from there and you can have an avulsion. Please don't forget this. This is how another case where they develop like an osteochondroma, and you can confuse this. Please keep this in mind. What we have, this is an MRI showing an avulsion of the rectus femoris. What about this? This is an avulsion of the hamstrings, of the adductor magnus. This can be confused with the tumor. People will be afraid of this. But lucky, if you do know about it, if you do know that this exists, you have no worries. you will be the master in the case. You can see it further over here. And this happens in runners. I'll tell you something, with the sports being so common these days, you see many of them. We see many of them, like we're seeing Lisfrank's injuries, which I'll be discussing at the end, I hope, today. This is an avulsion fracture of the lesser tuberosity. When you look at this X-ray, I want you to knock your head on the wall and say, what could this be? What we have, I've had several cases being sent to me and saying, hey, this is an avulsion of the lesser trochanter. My friend, I had 8 such cases. 7 of them turned out to have a metastatic lesion of the lesser trochanter. Be aware of this lesion. It's true that the lesser trochanter can be avulsed, but you have to think that metastasis, if you have an older patient in the 50s, metastasis from a primary lesion can occur over there. Okay, so keep this in mind. Don't forget this. The symphysis pubis can be also from rotational injuries during sports. Twisting, it gives you osteitis symphysis pubis. You have to think of this. And you can have adductor avulsion injuries. Okay, so don't forget about this. Now, what is the snapping hip syndrome? The snapping hip syndrome is an audible snapping with hip flexion and extension. And it is symptomatic most of the times, but it can be asymptomatic. When a person comes and says, look, I have a clicking sound over here. What do you think it is? Well, this is an external type of impingement. You also have an internal type and you have an intra-articular type. I will be discussing these briefly. This is the iliotibial band. As it passes near or in line with the greater trochanter, it rubs on it. It's rubbing. There is a bursa over there which becomes inflamed. And this gives you the clicking, the snapping sign. And if there's pain, it's secondary to inflammation of the bursa. Okay, so you'll have thickening of the iliotibial tract on magnetic resonance imaging, and also of the gluteus maximus. You have a trochanteric bursitis, and this occurs running on hard surfaces. This shows it further, showing you the increased signal intensity. So you have to be very careful about this. Now, we also have an internal. The internal is when the iliopsoas rubs on that pelvic brim, and there is a bursa over there, and they will have pain in the pelvic brim. And you can diagnose it by injecting. You see that there is inflammation, or you can do an MRI, and you can infiltrate it locally. At times, it's so resistant to treatment that you might have to either lengthening or remove the bursa or perform any other type of surgery. Now, this is as an internal. We said internal, an intra-articular part. The other one, the iliopsoas, was internal. The iliotibial tract was an external, and now an internal. And this is what we call femoral acetabular impingement. You can have a cam, you can have a tethering of the labrum of the acetabulum, or you can even have loose bodies, which give you a snapping hip. So a snapping hip can occur from the iliopsoas rubbing on the pelvic brim. It can occur from loose bodies in the hip joint. It can occur from a cam impingement or tethering impingement from the labrum, and it can occur from the iliotibial tract. So you know, fellows, you know that this is present. Don't tell me there's no excuse for not knowing this. This is showing a cam, and over in the middle slide of the slide, you get a tethering, a tear of the labrum. Mind you, in the hip, it is much more resistant to tearing than in the shoulder. Okay? And of course, you can get tethering secondary to dysplastic. You can have it secondary to slipped capital femoral epiphysis. You can have it secondary to leg Percy's disease, any irregularity. So this is showing the labrum of how firm in a normal individual. And then on the left side, you see that it's torn. It is torn. You can see it. It's firmly attached. And I want to show you one which is more clear over here. We call it the pincher impingement acetabulum. Likewise here, it is torn. You see that there is a radiolucency within the outer edge of the labrum. This shows you the labrum, and it shows you what impinges on the cam, and it shows you tethering or the pincer phenomena. All these give you a snapping hip. They give you a snapping hip. Don't forget this. Now, running athletes can have tears of the rectus femoris, and this should be confused, should not be confused with tumors. I've had a patient who had a malignant fibrous histiocytoma who ended up having a hematoma, and the intervention radiologist mentioned that this is a simple hematoma. Turned out to be an MFH, malignant fibrous histiocytoma. You can have tears in the gastrocnemius of the plantaris tendon, and on T2, it will give you an increased signal intensity. You can have stress fractures of the distal femur. I'm trying to go fast. You can have avulsion injuries of the knee, ligaments. All these are helped. You have to be aware of the normal appearance of the anterior cruciate ligaments. You have to be aware of the anteromedial and posterolateral ligaments, which is the component of the ACL. You have to know what the notch sign is. When you have a tear of the anterior collateral ligament, ACL, you get an empty space like this with grayish appearance, not fullness in the notch. And this will tell you that there is an avulsion of the femoral attachment of the ACL. Another point, you have to think of tears that occur posteriorly. You have to be aware of the Segan sign. Segan sign is an avulsion of the tubercle. This occurs with an ACL tear, and I'll tell you later on how that. And you have to be aware of tears with avulsion of fragments of bone from the insertion of the ACL. You have to see over here. Over here, you have an impingement of the condyle of the femur. What has happened is the ACL has to be torn to move posteriorly, and this condyle impinges on the posterior margin of the tibia, and it gives you this sign. This gives it more detail. Impaction of the lateral femoral condyle against the posterior tibia. With an ACL tear, this happens. So these are them. You have to think of the Segan sign, which is an avulsion, which is in association with an ACL tear. Okay, so keep this in mind. And this is a normal PCL. it's injured by a dashboard injury, and you can get a tear, and MRI is quite accurate in diagnosing it. You can have this is Gerdy's tubercle, the biceps. You have avulsions or injuries of the patella, which I will not be going through. This is a patellar dislocation with a Harrington fragment of the patella. It can be off the femoral condyle, the lateral femoral condyle, and you can have a tear of the medial patellofemoral ligament. All these become apparent by MRI. Okay, so you have to be careful about this. You have to pay attention to the ligaments. You have to pay attention. This is an old tear of the medial collateral ligament that we call Pellegrini stiatus injury. You have to look and know how to read meniscus tears. If you look at the meniscus and you take cuts of them, you see the cut on the outer edge is as is, then you know there is wedging inside. The cut becomes more oblique and then it becomes discontinuous. These are the cuts we see on sagittal views. This is an intact meniscus. This is an intact meniscus, but with a globular intrasubstance. This is a globular intrasubstance signal, and this is a linear intrasubstance. There's no connection with the surface of the meniscus. This, you have a connection. This is a grade 3 tear. Okay, grade 3 tear. This is a grade 3 signal where you have an extension of the tear. Over here, you have a vertical tear of the meniscus. Over here, we have a complex tear of the meniscus, many fragments. At times, you get a severe injury of the meniscus and you have loss of substance. You have the meniscus becomes a loose body. You have to keep this in mind. Here, this is one where you have a loss of substance and the meniscus was found in this area. So you have to pay attention. Likewise over here. Now, what is this? This is a bucket handle tear, the medial meniscus, and this is the posterior cruciate ligament. Many are confused when we show them this MRI. This is wrong. It's very easy. This is a medial meniscus, which is bucket handle, طلع الbucket, and this becomes parallel with the posterior cruciate ligament, and it gives you a double PCL sign. Now, over here, this is a ligament that is usually confused with tear. You know, this is the anterior attachment of the meniscus. We think it's a tear, but this is the anterior transverse ligament over here. It's called the anterior transverse meniscal attachment. It attaches the anterior horn of the lateral meniscus. It mimics a meniscal tear. And then you have to know about the ligament of Risberg and Humphrey. These can be confused with ligamentous tears. These are posterior ligaments. It attaches to the posterior horn of the lateral meniscus. It mimics a meniscal tear. These are the Humphrey and the Risberg ligament. Note these. You can have fluid tracking through the popliteal tendon, cheese, and the patient can have inflammation and pain. Don't forget about the discoid meniscus, which is a fully full meniscus that covers the surface. It's more common in the lateral meniscus. You have more than 2 bow ties. The lateral meniscus, there's an increased risk of meniscal tear in these. This shows you a horizontal tear. And this shows you calcification of the meniscus. And this is chondrocalcinosis. You can have also calcium pyrophosphate deposition disease. We know that hemochromatosis, where you have increased iron, can give you calcification. Hyperparathyroid disease, Wilson's disease, all these give calcification of the meniscus. Don't forget that you can have also fluid in the knee. And what happens is that the fluid pushes the fat forward, and in intra-articular fractures, you see them as globules. This is a Baker's cyst. What we like to ask about the Baker's cyst, where is the location between which tendons, which is lateral and which is medial? The medial head of the gastrocnemius lies lateral, the semimembranous tendon lateral. This is a type of stress fractures that can occur approximately. Don't forget this. Don't forget these stress fractures. I spoke to you about them at the beginning. Don't forget these happens quite commonly in ballet dances. Don't forget about tears of the Achilles tendon, where you have thickening of the Achilles tendon, and you have an anterior protrusion on MRI, and you can get avulsions from the origin. So don't forget this. Don't forget about Tom, Dick, and Harry. Don't forget where the vessels lie between the digitorum longus and the flexor hallucis longus. Don't forget about the tibialis posterior, which can be damaged, can be insufficient, can be lack of circulation, because we have a watershed zone in the tunnel for the tibialis posterior, and this can rupture. You see that there's fragmentation. You see it more clearly over here. Don't forget that the tibialis anterior can rupture by a force in plantarflexion while it's undergoing dorsiflexion. Don't forget about the peroneal tendon, especially the peroneus brevis, can tear and lie. Each of the fragments lie on each side of the peroneus longus, as is shown over here. You can see it over here. You see the peroneus brevis, and peroneus longus. This shows it by the arrows, the yellow arrows. And don't forget that the superior peroneal retinaculum can be torn in sports injuries, as is shown over here. These are well demonstrated by MRI. We have special coils for them. So don't forget about disruption of the superior peroneal retinaculum. Okay, don't forget about the tarsal tunnel syndrome. Any ganglion can apply pressure, and as a result, patient will have pain in the foot on the plantar aspect of the foot and medial aspect. Tarsal tunnel syndrome is a compressive neuropathy of the tibial nerve at the level of the tarsal tunnel, which can lead to pain and paresthesia of the plantar foot. Diagnosis can be suspected clinically with burning, pain, plantar foot pain with a positive tenderness sign over the tibial nerve, and it's diagnosed by electromyography and nerve conduction studies. This shows you a ganglion present in the tarsal tunnel. Don't forget that you can have osteochondral fractures secondary to injuries. You should know the classification between completely loose and a fixed osteochondral fragment. Don't forget about the avulsion process, of the lateral process of the talus. We like to ask this a lot because this can be large and it can go into the subtalar joint and give the patient late arthritis. And this occurs in snowboard injuries. This is a snowboard injury. And this shows you how it's avulsed. Don't forget about synostosis. You can have chondrosis, synostosis, and synfibrosis. An MRI would show it very well. And the CT scan, definitely. They will be well demonstrated by CT scan. I think in CT is far more accurate than in MRI in demonstrating. You can have a calcaneonavicular, calcaneal, and a calcaneocuboid. Don't forget these findings. There is another sport injury secondary to overdoing where you get a longitudinal fracture of the navicular bone. You can see it over here. I'm going to show it to you by pointer. Here. We see this. We're seeing it quite often with the increase of sports. This shows it further. And last but not the least, you have to think of Lisfrank's injury. We're seeing it more often in sports on plantar flexion injuries, where the whole metatarsus can be displaced, either laterally, or the first metatarsal medially, or it can be both ways. And at times you have a fragment of bone, which is called the fleck fragment. And this is a avulsion of the Lisfrank's fragment, okay, between the cuneiform and the second, metatarsal. So this is all, and I tell you, thank you very much. Any questions? Any questions, Khalid? ما في. يلا. Khalid. يلا, have a good time. أنا بعتقد زهقتكم يمكن، بس أعطيتكم كل شيء. I think I did nearly a complete review of
دكتور جون. دكتور جون.
خلصنا. شو بدك؟ بدهم
ايوه
يسألوا
خلصنا، لكن شكرا لك، واحنا مش زهقانين، بالعكس الشباب كلهم بيسلموا عليك ويشكروك.
طيب وانا هلا بحكيك على التليفون. اوكي.
ها؟
هلا بدي اطلبك على التليفون.
يلا خلص، حاضر. شكرا لك.